learning. Thank you and welcome once again. It's my pleasure to introduce and welcome our first speaker for the second day, Mr. Rajesh Kumar Tiwari. Mr. Rajesh Kumar Tiwari did BTech from JK Institute, Allahabad University, and completed MTech in Control and Automation from IIT Delhi. He joined DRDO in 2003 as a scientist B in Defense Electronics Application Laboratory, Dehradun, where he designed DDS-based QPSK modem for satellite communications. He also worked in design and development of laser warning sensor and optical target locator in Laser Science Lab, Delhi. Presently, he is scientist F and heading cognitive control and machine learning CCML group at INMAS, Delhi. Before joining DRDO, he has also worked as GSM engineer at Usha Phone and automation engineer at Tata Steel Jamshedpur. Sir, we are honored to have you with us today and we look forward to gaining valuable insight from your expertise. Welcome, sir. Over to you, sir.
Thank you, ma'am. Thank you all. I am very happy and I am delighted to join this your esteemed program, FDP program. And the topic is no doubt is very challenging and whatever we do and some kind of medical imaging now we do and AI applications also we try to implement for automatic detection of the disease or some kind of basically footprinting. Is it audible na? All to all?
Yes, sir.
Yes, sir. Yes,
It's
sir.
audible.
Okay, okay. So I am just sharing my slides and just 1 minute. So that I will cover the basic this topic, which is medical imaging in AI, and I will touch upon the basics of basically of some kind of medical imaging, and then the use of AI, and one case study, and the future R&D scope in this medical imaging in AI field, and in conclusion. Is it visible now?
Yes,
Yes, sir.
Okay,
Yes, sir.
okay.
visible.
Make me basically I am just doing the slide presentation mode. This is basically medical imaging in AI, the topic which you have suggested, and this is basically assigned. The presentation which I am covering, the brief introduction of medical imaging, what we understand with medical imaging, and some kind of basics and research area in medical imaging, and medical imaging with AI, basically the applications of AI algorithms, and one case study which we have implemented in our lab. That application we will share and the kind of conclusion. So when we say the medical imaging, it briefly refers to the techniques and the processes used to create visual representation of the interior of the body for clinical analysis. So basically, anything, any question?
No, sir. Rajni ma'am, आप म्यूट कर लीजिए. Mute yourself, ma'am. तिवारी sir, please unmute yourself.
Hello, now is it audible?
Yes, sir. Yes, sir. It's
Okay,
audible.
okay. So basically, the basic definition of medical imaging, what we understand with this definition, is about the techniques and the processes used to create visual representation of the interior of the body for basically clinical purpose or your medical intervention. It may be. It may be the visual representation of the function of organ or tissue for the R&D purpose or some kind of extensive exploration point of view. So the physicians diagnose and monitor and they treat disease effectively. The basic importance in modern healthcare for this medical imaging is now the earlier diagnosis Non-invasive, obviously, this is a method. So non-invasive method is there. A precision in treatment, because when you find out all the aspects available with you, and the patient monitoring, you can monitor regularly with the with kind of medical imaging. And when we talk about the role of the 3D imaging in diagnostics, so obviously it comes for the help of your enhanced visualization. And when they are the complex case, so you can easily also manage these kind of cases with the help of data analytics, personalized medicine, and improved surgical outcome. These are the few images which you can see: the CT image, CT scan, MRI, and the X-ray. These generally helps us to visualize the kind of problem we face or the patient faces. When we talk about the medical imaging, the basic concept in medical imaging depends upon the radiation. So there are the two kind of radiations, because we all are the electronics engineers, so we can understand the electromagnetic radiation is there, and the other is the particulate radiation. Electromagnetic radiation, all of us know the radio frequencies, infrared, visible light, and basically electric and magnetic field, which is perpendicular to each other, and perpendicular to the basically propagation of the your wave. And ultraviolet rays, X-rays, gamma rays, these comes under the electromagnetic radiation. And the particulate radiation basically defines the radiation with the help of electrons, positrons, protons, and neutrons. And these are the nuclear radiations, or we can also call them the nuclear radiation. When we see the electromagnetic radiation spectrum, so obviously wavelength in terms of wavelength and the frequency. So radio frequency and the MRI, this comes under the basically up to the gigahertz, and then it starts infrared and ultraviolet, and then goes for the gamma rays. And we see that X-rays, generally X-rays, when we it is in the range of ultraviolet range, UV rays, then it comes for the diagnostic purpose. But when we increase the basically wavelength, so frequency, then it can be used for the therapeutic application for the cancer treatment. And in terms of energy also, EV, we can see this radiant. When it is less than your visible range, nanometers, then it gives the radiant heat. And higher than the visible range, it gives the basically cosmic rays. And the photon energy obviously is expressed in the terms of the electron volt. So electromagnetic radiation, when we talk about, then interaction with the matter considered in terms of the photons, basically. The photons we know E is equal to h nu. And in diagnostic radiology, the photon energy is usually expressed in terms of the kilovolt. So 1 keV is equal to 1000 electrovolts. So whenever you see some kind of data sheet or specification, then you just find out that this is expressed in the terms of kilovolt. And when we talk particulate radiation, the diagnostic radiology, the only to be particulate radiation that considered is the electron. So electrons, generally, when we talk the rest energy of the electrons is terms of MeV, a 0.511 MeV. So whenever you see the radiation center in any hospital or anything where the radiology department is there, this kind of specification or values are being displayed there. And the effect, when we categorize radiation in terms of ionizing, non-ionizing point of view, non-ionizing means it cannot ionize the matter. So these are the basically RF waves, electromagnetic radiations, which is the energy below the far UV region. So visible light, infrared, and radio frequency, these are called the non-ionizing radiation. And then ionizing radiation, basically it can ionize the matter. So basically X-rays, gamma rays, and the neutrons, these are called the ionizing radiation. And ionizing radiation can ionize matter in the two ways, directly or indirectly. Fast charged materials that deposit their energy in the matter directly through many small Coulomb electrostatic interaction with the orbital electrons along the particle track. So this is called the directly ionizing the material. And indirectly, X-rays or gamma rays or photons or neutrons. Ah, X-ray, gamma rays, neutrons transfer their energy. It is I'm not able to shift this to the right side, basically. Yes, okay. Neutrons that first transfer the energy to the fast charged particles released in one or a few interaction in the matter through which key passes, the resulting fast charged particles then deposit their energy directly in the metal. This is what why I am covering because whenever you talk any medical imaging basics, so this kind of ionization or non-ionization radiation is being considered and expressed. So like when interaction of radiation with matter is there, so if when basically when just I saw that photon and electrons are there, and they basically as they traverse matter are stochastic and obey the laws of change chance, although they very different behavior. Photons in generally when we see the few interaction, exponentially attenuated photons interacts with the express in terms of cross section of individual interactions. So these generally when we see the interaction of the photons, this is directly related with the cross section area. Cross section area is defined basically the slab of material area. If we say A and the target of one cross section is sigma, then the ratio is sigma by A. So the interface where this is interacting, photon is interacting, is called the cross section area. And when we see this photoelectric effect, so the cross section is when we in terms of tau, coherent scattering and incoherent scattering. Coherent scattering is like your Johnson scattering or Rayleigh scattering, where we define cross section as in terms of the sigma coherence and sigma incoherent in terms for the incoherent scattering. And when high energy is there, then pair and the triplet production is also there. Energy loss, like when we now we just see the photons in similar way. When we see the electrons is also they either they ionize or colloidal losses are there, or they do the radiation losses. So when in terms of ionization losses, the principal process is basically collisions with the electrons whenever they interact with the matter. So either they will lose their energy with the collisions, or in the direction of basically change in the direction can be quite large also. The electrons which leaves the collision with the most energy is assumed to be the original incident electron. This means that maximum energy changes in half of the original energy. So maximum what we considered, the half of the energy has been lost in the losses. And when we see about the radiation losses of the electrons, the interaction with the electric field of nuclei and be dissipated so rapidly that some of the energy may be radiated away. So radiation loss generally whenever there is interaction with the nuclei. Modality of 3D imaging, when we see the imaging, there are the four kind of, generally five kind of imaging is being observed. Like one is CT and the other is MRI. A third is generally common X-ray, 3D ultrasound is there, and PET, positron emission tomography is also there. So various disease, generally we what disease kind of identification which is being used, I have broadly mentioned them. Now for CT, generally we use for the cancer detection, trauma imaging, vascular imaging. And MRI is generally being used for the neuroimaging, musculoskeletal imaging, cardiac imaging. Generally, it is for the soft tissues purpose. X-ray is orthopedics, chest imaging, dental application, mammography, where the generally hard tissues or your bones are concerned, then X-ray is being used. 3D ultrasound, this is for obstetrics, cardiology, and abdominal imaging, where your real-time imaging, when you see, then this ultrasound is being used. PET is generally used for the oncology, neurology, and cardiology, and this is being injected with some kind of nuclear medicine to see basically the dye or some kind of contrast. Some basics of basically operation principle of the medical imaging devices I have mentioned. These are commonly used. The CT, which is full form is computed tomography, and the CT refers to basically computerized X-ray imaging procedure, in which a narrow beam of X-rays is aimed at the patient and quickly rotated around the body. Basically, the small kind of sources and detectors are there, which is placed across the basically some kind of a gantry, and it is being rotated. And tomography is derived from the Greek word tomos, means slice. So generally, when we see 128 slice CT and this kind of CC, it means these kind of sections has been taken for the 2D or 3D cross section image. And this is mentioned basically your some kind of this D is detectors are there. This is a source, and this is a gantry rotation where it is rotating, and this is X-ray beam. Principle basically when CT scan, I mentioned this, it is attenuation of X-rays whenever this passes through the different parts of the body. So how much attenuation is there, and with the help of that intensity, it is the area, the basically the cross section area is being projected to reconstruct the cross sectional images. Basic mathematical concept, and what we use the random transform and its inverse. And reconstruction of the original image involves the inverse random transform, which can be approximated using the filtered back propagation FPB, and the projection data is filtered to remove noise, and the back projected to reconstruct the basically image. When we talk about the ultrasound imaging is generally basically echo pulse based on the pulse and echo mode. And there are the two kind of ultrasound imaging, A mode and B mode. A mode is generally called the linear mode, and B mode is when we design, when we take the information in the 2D. It means when we move that linear in the other direction. Basically, we plot the two-dimensional image based on the pulse echo acquisitions. So focused by the relay and some beam forming process. Generally, what we do when we repeatedly send the pulses and the reflections come back, and then we make the delay and some process, beam forming processes, and we demodulate to obtain the magnitude or envelope of the echo signal. So when we do A mode linear imaging, then what we do, plot echo magnitude as a function of distance. And in the B mode, what we do, increasing basically scan line direction through the each pulse echo operation, and this sweeps out the 2D or 3D field of view. The B mode imaging, because the echo magnitude from each point of the view or each point in the field of view is mapped to the gray label. That gray label is called the brightness also. Basically, it is the intensity of the corresponding pixel in the image. This is for used for the the real time imaging. And when we array system principles are there, three methods are there for the B mode imaging. One is linear array, when we move basically the scan line in the linear direction. Other is curved linear array, where we have a path, a curved path, and we process this scan in that direction. And the third one is a phased array. And for phased array, we have find out the phase difference, and we find out the basically, and then we plot that into as a function of the intensity also. MRI also a magnetic resonance imaging. Basically, it is a non-invasive magnetic imaging techniques that uses strong magnetic field and RF waves to generate the detailed image of the body internal structure. Here also we use the RF.
ठीक है.
Any issue, sir?
No, sir. Please continue, sir. No problem.
Particularly soft tissues are there. So generally, by detecting the signals from hydrogen nuclei, basically here the protons, we detect the protons, and then we generate the RF. So basically, MRI acquires image by detecting signals from hydrogen nuclei in the body. A strong magnetic field aligns the protons. The radio frequency pulse excites them. As protons return to their equilibrium state, then they emit RF signals, and which are detected by the scanner. So this is the basically imaging mechanism with the MRI. And gradient coils are there. Basically, spatial encoding is achieved using the gradient coil. So this is MRI is a gold standard for the basically your spatial resolution. And anything which is like for neuroimaging or tissue related imaging is there. And for brain imaging, we call it fMRI, functional MRI. And this gives a very good 3D resolution in spatial domain. Signal processing, the emitted signals are digitized and processed using the Fourier transform and techniques to reconstruct the image. And basically, they are the two weighted imaging, T1 and T2. T1 is basically when repetition time, echo time is adjusted. And when we achieve the longer time, then it is called the T2 weighted imaging, where basically edema and some kind of inflammation is there. Then we use T2 weighted imaging. And generally, for the fat or soft tissue, we use the T1 weighted imaging. Basic mechanism, if we talk about the schematic point of view, there are the three basic fundamentals, basic systems for the MRI. First is static magnetic field subsystems, where we define in terms of the Tesla. So generally, resistive solenoid is less than the zero point 0.5 Tesla, but superconducting magnet and basically clinical use, we use zero point 0.5 to 3 Tesla. Generally, you can find the 1.5 Tesla or 3 Tesla MRI system. When in our INMAS, we have a 3 Tesla MRI. And now the experimental clinical use generally 3 Tesla to 8 Tesla, and 7 Tesla is now the latest one which is coming for the more resolution. It can give the instead of pixel, it will give the information in terms of voxel also. So three different superconducting magnets generally we use in this MRI machines. They are either of Siemens or Philips or GE. These are the main market players which generally provide this kind of superconducting magnets. Radio frequency subsystem surface RF coil transmit basically is smaller than the body coil. These are the basically for transmission and positioned over the volume of the interest in the body. These are some enclosure is there where the specific part of the body is moved inside that enclosure, and that is positioned for to cover the volume, particularly for multinuclear measurement. And when we surface use coils for the receive, it provides an increased signal to noise ratio from small volumes, flexible designs for many parts of the body. So this is receive parts. Basically, generally we use the flexible design for many. And gradient coil design and specification. These are basically some kind of requirement for gradient coils where we use spatial localization of the image formation governed by the three orthogonal set of the coils. They are the three sets of the coils placed. Superimpose the field gradient. Whenever the field is basically applied to the three vectors of this B0 field, which we saw in the terms of RF waves. So all the three components are basically superimposed. Generally, X usually horizontal orthogonal to V0 direction, Y usually vertical orthogonal to V0 direction, and Z basically in the direction of that along V0 is the Z axis direction. These, with the help of these basically orthogonal components, we place and spatial localization of the image. And then all the data is being sent to the computer and control system. There is a command control system is there. Then you can see in any MRI station, which gives the basically resultant spatial uh, uh, image of that affected part. New trends in medical imaging now they are emerging is the terahertz light. Terahertz is a new field which generally gives you more resolution and more deep insight to the basically imaging. This is the R&D field which is going on for medical imaging point of view. Still, generally, now it is being used for the destructive, non-destructive testing of your archaeological kind of basically investigation. So this is terahertz gap comes under the 0.1 to 10 terahertz, and it fills the gap of electronics and photonics. And wavelength generally 3 millimeter to 30 micrometers. Energy is 0.41 to 41 millivolt, and wave number obviously temperature is there. So I will show some kind of basically application. When we talk about the terahertz imaging and spectroscopy, and you see that penetration depth and this more generally maximum materials which are being used nowadays: polyethylene, Teflon, PMA, mylar, silicon, polystyrene, glass, Vesla. These all being penetrated and with some kind of your basically penetration depth. It is being mentioned. And advantage of terahertz is basically it is a low energy millivolt non-ionizing radiation. So it is not like the X-ray basically. Many materials are transparent to terahertz. It is good penetration. Many molecules, rotation and the vibration absorption mode, spectral fingerprinting. Basically, it can be used in the spectral fingerprinting. And you can see this kind of basically it is also we can say it is like gated imaging kind of thing. I will show you one example where we can find out the basically the depth of the different layers also. So but challenges in terahertz imaging is it is difficulties in developing the high intensity terahertz. Okay, generally the low energy is being used. So if we want to design terahertz in a high intensity and then efficient detectors is a challenge. Lack of efficient materials and devices to manipulate terahertz radiation, and water absorption could be a problem. Generally, water is a strong absorber and metals are opaque. So basically, it gives the possible contrast, but sometimes water absorption may be a problem. This can be a challenge. When we talk about the IEEE standard for terahertz, it is 802.0 15.3D, and which comes of the MAC layer, and it also that being used in the communication also terahertz. It now the after 5G is the 6G, where the blockchain terahertz AI in fully intelligent and TBPS terabytes per second. So AI Internet of Everything will be expected in the 2030. Nowadays, this IoT kind of thing is being used, where the OFDM is the main player. So this is a challenging field where basically, as far as communication is concerned and your imaging concerned, terahertz is a important field. And pulse terahertz basically it gives you, as I told, like gated imaging kind of thing. So it gives the basically frequency and the time domain, the depth information also. So like for example, if you want to check the basically different layers, thickness of different layers of the chip. So if you are sending this pulsed form in the pulse form. So where the first reflection is from even out, and the other reflection is from this edge when the refractive index is changing, and the third when the third change is there. So the other reflection is there. So E1, E2, E3, these three reflections are there. So you can find out the different images of the different layers, because these are the ultra fast, less than picoseconds, and broadband images. Possibility of implementation sub picosecond snapshot imaging, time resolved imaging, it can be achieved. So in real time, we can check this like CT, etc., MRI. These are the basically your gives the spatial resolution. But if you want to check the real time, so this can be used as a one of the R&D field. And biomedical application, when we see the 3D and the composition information in a single scan, you can see this visible images for the teeth is like this. And when we see the time of flight image, so that there are two different layers are being observed in the when as a like gated imaging. The enamel is there, enamel and dentine is there. And for absorption image, physically you see that there's a cavity, but when terahertz absorption image you see, then there are different parts having different absorption, so you can easily find out the depth. So, and in skin case, if we see the skin tissue visible image is like this, which is of a 4 mm dia, this part. If you see in the different parts in different layers, then the refractive index as well as the different depth is there within the 4 mm also. So you have a much more clear view. And basically the biomedical application we do generally there is a setup, experience apparatus in terms of basically where the some kind of small tissue is being placed, and the femtosecond pulse laser, it has been divided in the orthogonal component, and with the help of a projection in the phased difference, the image is being created. And like you can see, this is a human breast tumors. It looks like this with different intensity of different parts is there. And similarly, a mouse prostate section with the tumor tissue, this circle, this is a prostate, this a tumor is there. So it is being more, you can optical 1 mm slice is there. You can more visualize the image. If you have a clear data and good quality data, so obviously then AI can be used much more effectively. Role of machine learning in medical imaging, we see. So then machine learning is providing robust solution for healthcare professionals to improve diagnostic precision and streamline workflows. These advanced algorithms offer powerful tools that significantly enhance the capability of traditional imaging techniques. Convolutional neural network CNN excel at analyzing complex radiological data, enabling rapid detection of the suitable substantial abnormalities in X-ray, CT scan, MRI. For instance, these algorithms can identify lung nodules in chest radiographs or segment brain tumors in MRI scans with remarkable precision. Support vector machines and random forests are employed for tasks uh, such as classifying breast lesions and mammograms or predicting cardiac events from coronary CT angiography. Furthermore, deep learning modules have shown promise in the automated image reconstruction, reducing noise in low dose CT scans and generating detailed reports. Basically, when we have a low dose CT scan, so obviously there is a less contrast. So if we want to increase the signal to noise ratio, so basically deep learning models are more effective if we have a good source of CT scan database. In real-world application, machine learning algorithm assists radiologists in detecting early signs of disease like Alzheimer, cancer, potentially improving patient outcomes. These AI-powered tools not only expedite image representation in image interpretation, but also provide consistent result across the different practitioners, minimizing human error. So basically, the explanation what I want to say, whenever the human intervention is there, and we generally see in our case also, the different basic radiologists give the different opinions, and they have some give the long report, some give the short report. But if it is based on the AI power tools, obviously this is there will be some kind of uniformity is there. Clinical application of AI in medical imaging when AI in radiology. Basically, medical imaging is nothing but the radiology is basically. So AI powered tools outcome time consuming task, such as image segmentation, annotation, and allowing radiologists to focus on complex cases. Basically, ये जो AI powered है, this is automate the time consuming because your radiologist has having a different task and they can give the different inputs. If they get the automated result with this AI, and they can scrutinize their results, and they can do much more other works also. Otherwise, the same for the same task, they will be much more occupied. And obviously, the critical cases they receive immediate attention also. So if something is alarming, they can find out. A notable success story, if we see that earlier stories where the AI played an important role, it was the basically from Stanford University where the researcher developed a AI system that outperformed human radiologists in depicting the pneumonia from chest X-ray. So in expert generally radiologist, they have the growing learning phase, or maybe they are expert, so their variety of experiences there. So maybe they have some kind of lacking in the explaining the basically pneumonia condition. But Stanford University showed the result where the AI outperformed the basic radiologist. And the case study was the AI assisted mammography screening at the Massachusetts General Hospital, and they reduced the false positive by 30%. So obviously they increase the efficiency and the sensitivity of the cancer detection. They maintain that. Consequently, patients also experience fewer unnecessary follow-up procedures and reduce anxiety. So, if there are these kind of tools are there, so obviously, if proper information has been given, so they can reduce their follow-up procedures also. Furthermore, AI algorithms have shown promise in the predicting patient outcome based on the imaging data. Like for example, deep learning model they developed at the Mount Sinai Hospital, and for forecasted long-term mortality risk from chest CT scans. Generally, these chest CT scans, even though they have low intensity exposure, but this can also cause some kind of your cancer kind of thing. So they just basically explored how much long-term mortality risk is there for these kind of chest CT scans. Benefit of AI in medical imaging, obviously, the improved accuracy and precision is there, as I explained, because human can do some error, but uh, uh, AI, if it has a good database and good kind of basically the good quality CT or medical imaging results are there, so they can perform much more better. Enhanced image analysis and interpretation, and basically you can you can analyze the image and reduce the diagnostic errors basically, and increase the confidence in clinical decisions also. Impact on precision medicine. The AI integration supports precision medicine by combining imaging data with patient history and genetic information, creating comprehensive profile for personalized treatment plans. Basically, for every patient is different and having a different kind of personalized treatment plans are needed. So this can be used for basically precision medicine point of view. Clinical benefits, AI reduce variability among radiologists. As I told, okay, there is some kind of different radiologist explains different kind of information. Some is hidden, some they have not mentioned clearly, and some they have over exaggerated. So this kind of basically uniformity can be maintained with the help of AI. Data management analysis, obviously large volumes, data-driven decision making. These are the important points which where the person basically we can see the importance of AI can be uh, can be basically the main role of the AI can be used. When we talk about the medical imaging in AI, the basics are generally when we do image post-processing analysis, all these things basically what we do is get the data and or we do post-processing analysis. So there are the few points, the steps, generally deterministic image processing and feature enhancement. These are the standard tools, standard methods are available. And then image segmentation, image registration. Open source are available and with the tools for image analysis. Segmentation algorithms were developed to detect and extract specific anatomical objects in images, such as malign lesions and mammograms. Registration algorithms were developed to align images of different modalities and to find corresponding anatomical location image from different subjects. So these are the basically main steps which we follow in the post-image processing analysis. When we talk about image processing and image analysis, these are the two different things. Main features that distinguish image analysis from image processing is the use of the external knowledge because you are analyzing and external knowledge about this object appearing in the image. This external knowledge can be based on the your heuristic knowledge and your physical models, your data obtained from previous analysis of similar image. This information is basically embedded when we want to analyze the images. Example of image analysis is a biomechanical model of the heart may be used by an image analyst algorithm to help find the boundaries of the heart in the CT or MR image. This model can help the algorithm tell true heart boundaries from various other anatomical boundaries that have similar appearance in the image. We want to differentiate, then we have to train, and with some kind of model we have to design, and this comes with the help of image analysis. Image segmentation is when we talk the image, the problem of finding object in image is generally called the segmentation. All of you, many of you may be knowing this. It is central problem in the field of image analysis. It is also a highly complex problem and there are the many challenges. For example, the heart segmentation CT is very different from the heart segmentation MRI, and this is very different from the brain segmentation MRI. So when the three kind of data is available, we want to merge or we want to fuse them. So obviously there are the different kind of segmentation there. Some structure move during imaging while other structures are almost still. So this is also a problem, challenge is there. Some structure have a simple shape that varies little from the subject to subject, while other have complex, unpredictable shapes. So this is also a challenge. So image segmentation, this problem is a challenge. And if we overcome this kind of challenge in the particular application, so obviously it will give the good result. Image registration, when we say, so often in medical image analysis, we have to process the information from multiple images. Image with different modalities like CT, PET or MRI from the same object. Image require a different time point from a single subject. So obviously there should be some kind of sync is there because the operating principle of all these modalities is different. And when we take the data of the same object and obviously the time delay and the time synchronization is also very important when we want to register the image. Images of the same anatomical regions from multiple subjects. In all these and many other situations, we need a way to find the align corresponding location multiple images. So, image registration is a field that studies optimal way to align and the normalize images. So, image registration and image segmentation are the two most important aspect in terms of AI application, where we want to acquire the image or we want to basically register the segment the image. Deep learning algorithms generally we use for this image segmentation or this medical imaging. Deep learning algorithms offer more accurate, efficient, and automated assessment. Deep learning algorithm is a subset of machine learning, obviously, and process large volume of medical imaging data to identify patterns, detect anomalies, assist in diagnosis, often with minimal human intervention. Training AI models with medical data is essential to their success. So the data-driven training is there, or there's a continuous training is there. These kind of two trainings are there. Deep learning algorithms require vast amount of the annotated medical images to learn and improve their performance. This allow for automated assessment that supports clinical decision making. And continuous learning, as new data becomes available, these algorithms continuously refine their accuracy. So these are two important aspects. So data, encrypted data, and the vast amount of image should be available. And then whenever new data is coming, then algorithms should continuously refine the accuracy. Enhanced radiology application AI models in radiology are currently used to detect features, tumors, and other abnormalities on X-ray, CT scan, MRI. Their high accuracy and speed is identifying subtle pattern make them indispensable in busy clinical environment. So by leveraging deep learning in medical imaging, clinicians can benefit from faster, more precise diagnosis and improved patient outcome. So these are the basically a tool which is being used for the basically for the help of the medical fraternity, so that the better quality of result and decision making can be done if the basically good amount of uh, 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 images or annotated medical images are available, and when the latest data is there, so obviously the algorithm should be redefined itself. And this is a case study which we have done in mass. This is basically intraganglial hemorrhage, and this is caused with the due to some kind of TBI, traumatic brain injury. It can be with the any ID blast or any shock waves, or basically if the patient or subject is fall down. So whenever then any army person or services persons comes and they have some kind of basic neural problem or some kind of change in their neural structure, then we find out what kind of hemorrhage or what kind of problem was there. So basically object detection, generally that computer vision is basically involves identifying the locating objects in the image and videos. Object detection algorithm can be divided into two categories. Basically, this is single shot detectors and two-stage detectors. And one of the earliest successful attempts to address the object detection problem was using deep learning was the RCNN, regions with CNN features models, developed by Ross Greensey and his team at Microsoft Research in 2014. This model used a combination of regional proposal algorithms and convolution neural networks to detect and localize the object in image. Object detection algorithms are broadly, as I told, is classified into two categories. Two-stage generally, RCNN, fast RCNN, faster RCNN, RFCNN. These are the variant of basically CNN. These are the two-stage detection algorithms. And YOLO and SSD, these are the latest one. These are single shot, one shot, or your proposal free basically object detection mechanism. So in case of this hemorrhage, ICH, basically object detection models, and I will also many of you know that what kind of matrices we should use. It is whether it is using object detection is being done. What are the parameters we should look for the in terms when we see the object detection is quality of that. So there are the two parameters. Intersection over union is there to calculate the IOU, where the area of overlap is divided with the area of union, and they are the expressed in terms of the bounding boxes. We first take the intersecting area between the two corresponding boundary boxes of the same object. Following this, we calculate the total area covered by the two bounding. As I have shown in this figure. These are the basically intersection area and the total combined area. This is the area of union. We see what is the ratio of that, and this also known as union and the area of the overlap between the called the intersection. So no issue. The intersection divided by the union gives the ratio of the overlap to total area, providing a good estimate of how close the prediction bounding box is to the original bounding box. So it gives the a good kind of prediction. Average precision AP is in other matrices where it is calculated as the area under the precision versus recall curve. When we plot this, then the area under this curve is given gives the AP, and recall is calculated as the ratio of the total prediction made by the model under a class with a total of existing labels for the class. Precision refers the ratio of the true positive with the total number of total predictions made by the model. So when we find out separately precision and then recall, and we take the ratio of this and give the basically it gives the average precision. We have used YOLO algorithm in our this case study, which we have done at our INMAS. So YOLO is basically defined as a you only look once. This is a short form. This is full form of this YOLO. Proposes using an end-to-end neural network. It is also a kind of neural network that makes predictions of bounding boxes and class probabilities all at once. It differs from the approach taken by the previous object detection algorithm, which repurposed classifiers to perform detection. Following a fundamental difference, what is the basic difference approach in the object detection? YOLO achieved state-of-art results in comparison to the older ones. While this algorithm has a faster RCN works by detecting possible regions of interest using the region of proposal network and the performing recognition on these regions separately. YOLO performs all its predictions with the help of a single fully connected layer. So method that use regional proposal network perform multiple iterations for the same image while YOLO gets away with a single iteration. So it reduces the basically your processing time. So this is basically proposed in 2015, and now this version, YOLO version 7 and version 8 are there. YOLO basics, we talk about some kind of basics. So basically key techniques used in YOLO model is non-maximum suppression. This is called NMS. NMS is a post-processing step that is used to improve the accuracy and efficiency of object detection. In object detection, it is common for multiple bounding boxes to be generated for a single object in an image. So basically in a complete single image, there is different segmented multiple bounding boxes are there so that in one pass, they can detect the number of objects available in this. These bounding boxes may overlap or be located at different positions, but they all represent the same object. NMS is used to identify and remove redundant and incorrect bounding boxes and to output a single bounding box for each object in the image. The YOLO version 7 is a basically latest version, and several improvements over the previous versions have been made. And one of the main improvement in this use boxes is called the anchor box. Anchor box is a set of predefined boxes with different aspect ratio that are used to detect objects of different shapes. So YOLO 7 uses 9 anchor boxes, which allows to detect a wider range of object shapes and size compared to the previous versions, thus helping to reduce the number of the false positive. A key improvement in this version is basically it is the loss function is called the focal loss. And previous versions YOLO used the standard cross entropy loss function, which is known to be less effective in detecting small objects. Focal loss battles basically down weighting the loss and well classified examples and the focusing on the hard example. Basically, YOLO, this focal loss, the new loss function gives the much more accuracy and well-defined classification. YOLO version 7 also has a higher resolution than the previous version. It proposes images at the resolution of 608 by 608 pixels, which is higher than the 416 by 416 YOLO version 3. So earlier versions having less resolution, while this version having higher resolution. And other advantage is the speed. It can process image at the rate of 155 frames per second, while the standard, the previous one maximum, they have a rate of 45 frames per second. Basically, when we talk about the intracranial hemorrhage, ICS, so there are the 4 types of hemorrhage are there. Which is basically with the help of CT image, we want to identify them. Basically, one is ICH, bleeding directly into the brain tissue. When there is a bleeding directly in the brain tissue, then what happens then? It gives a bright region in the CT image, often surrounded by the edema, swelling. There is a swelling and it gives the brightest spot. When there is a EDH, epidural hematoma is there, Then in CT image, what it looks like a convex lens shaped appearance is there. And SDH is gives you basically this is a subdural hematoma. It appears as a crescent shaped hyper dense area on the CT scans. And sub basically SEH form, where when the bleeding is in the space between the brain and the thin organoid membrane, then this kind of hemorrhage is given by the basically in CT image, high intensity blood in the cerebral or your vessel system are there. So it gives it basically your high density blood flow, a blood location, and so that you can easily identify. Generally, these are the more common hemorrhage types which is available in our patient in mass, and we have a one kind of data set so that we try to identify with the help of this YOLO algorithms. So basically, the type of hemorrhage we fed, and they are the JPG images are there, metadata is there. So we can identify the segmented image during the model training, and then segmented brain images there. Like you can find out the SDH and SDH and ICH. The different basically boxes are there. And the objective was to automate hemorrhage detection in the CT scan images, accurately calculate hemorrhage volume. Basically, we want to find out the volume of that, how much damage had been done with the patient, and provide a user-friendly web interface for the medical professionals also. So anyone which is using in our in mass, seeing the looking at the services personnel in the basically traumatic brain injury, so what kind of hemorrhage is there, so that the person who is handling there can give the result in the less time. The workflow is like the way we get the DICOM image files there, DICOM to JPG basically, that and metadata conversion is there, and then basically segmenting and hemorrhage using the fine-tuned model, and then that data is basically and the volume is being then we find out the volume also. So future improvements and the application basically for these applications are enhanced model accuracy with the more data, and basically the still we are not having a more than like we have a nearly 1,000 patient data is with us, but still if we have more data, so then we have a much more improvement. Implement 3D volume calculation and develop real-time detection. So whenever we have done some experiment with the EEG also. So rather than taking some this kind of CT scan images, if we put our CT basically EEG on the headset of the patient, and with the correlation of this EEG waves with this your CT scan, we will find out in the real time detection. And this is our future task which we are going to which we are working on there. An application is basically rapid trauma assessment in combat. These are the main applications, so that we can find out with the help of our EEG that what kind of hemorrhage is there. Automated field diagnosis for soldiers, remote medical support in the battlefield condition. If there is a more damage or more hemorrhage is there, so that volume as well as the kind of hemorrhage we can identify with the help of this images, AI, as well as your integration with the EEG, then it will be much more beneficial for the soldiers in the battlefield also. So medicine, ethical and the regulatory consideration, these are the more important aspects where basically what is the ethical point of view in using this AI. Several ethical and regulatory issues facing companies who are developing medical imaging using AI. The patient privacy and data security is much more important aspect. AI system requires access to large amount of medical data, raising concern about the privacy and the security of the patient information, ensuring compliance with regulatory regulations like HIPAA, the Health Insurance Portability and Accountability Act, is crucial to protect the sensitive data from breaches and unauthorized access. So this is a very crucial thing, because when we want more number of data, so obviously this privacy comes in picture. Bias and fairness, basically AI algorithms can inherit biases presently in training data sets, leading to the unequal treatment outcome across different patient demographics. It is essential to ensure that AI systems are trained on diverse and representative data sets to avoid perturbing or exaggerating health disparities. So obviously, whenever there are demographic changes there, and there's some kind of basically your baseline changes, then obviously then AI algorithm improvement is necessary, and we need much more data for that improvement. Transparency and explainability. Many AI models, especially deep learning ones, operate as a black boxes, making it difficult to understand their decision-making process. That is the main challenge. Enhancing the transparency and explainability of these models is necessary to build trust among healthcare professional and patient, as to ensure that AI-driven decisions can be justified and scrutinized. So, a validity of these results is much more needed, and for so that the patients can have basically much more confidence. Clinical validation and the reliability. Basically, AI algorithms must undergo rigorous clinical validation to prove their safety, efficacy, and the reliability. Because what we are doing is the R&D, and much more we are also facing these kind of challenges, because when it comes to the validity and the regulatory bodies like FDA, Food and Drug Administration, requires robust evidence before providing approving AI-based medical devices and systems for clinical use. So any integration with the AI medical devices, some kind of regulation is very much needed. Accountability and liability. Determining who is the responsible when an AI system makes a diagnostic error. That is a main glitch, a main gray area where we have to fix the responsibility or fails to detect a condition in the complex issue, because the patient life, a decision for the patient, and basically your, if there is some kind of error is there, then what can be done and who should be responsible. These are the challenges when AI technology in medical imaging is being used. Informed consent. Patients should be informed about the use of AI in their medical imaging and diagnostic. They must understand how their data will be used, the benefits and risks of AI-based assessment, and their right to opt out if they choose. So this will also be should be basically like when it is a standard practice in the medical field, when the patient goes and they give the consent, the same should be applied here. Ethical use of AI. Ensuring that AI technology are used ethically is paramount. This includes making decisions about the appropriate application of AI, avoiding over-relying on AI at the expense of clinical judgment, and ensuring that AI serves to augment rather than replace the human expertise. So basically, human should be in the loop rather than basically making it redundant. So AI should be like a helper, and obviously there should be some kind of uh, uh, basically vigilance, or you can say some kind of observation or some control is needed in terms of the human. Future direction in 3D medical imaging. When we talk about the quantum imaging technologies are there, the quantum imaging leverages quantum mechanics to improve the resolution and the sensitivity beyond the limits. Potential for enhanced imaging techniques that could detect smaller abnormalities with high resolution. Future impact will be basically application in the cancer detection, neuroimaging, high resolution tissue imaging. So these are the few challenges where we want to increase the basically resolution, so that can get more insight of the basically problem. Personalized medical medicine through advanced imaging like your precision diagnostics. Advanced 3D imaging technologies enable more precise, personalized diagnosis tailored to individual anatomy and disease progression. So example, using functional MRI, as I told you, for neuroimaging, functional MRI is doing, and 3D modeling to customize treatment plans for neurological condition. So, like in a neurological condition, nowadays, basically cognitive properties, cognitive decline is there, some kind of stress, anxiety, and these are the things are there. So if we want to give them the precise, basically customized diagnosis plan, so obviously we should have some kind of specific treatment plans, or with the help of some neurological your imaging with the advanced imaging. Tailored treatment. Obviously, advanced imaging combined with the AI will facilitate personalized treatment strategies based on the 3D scans, improving patient outcomes and reducing the side effect. So challenges are with the your medical imaging should be portable and more transparent, more give more resolution, and with the help of AI, we can serve the patient or our services more effectively. So conclusion, if we say in conclusion, the future of medical imaging technology looks promising with the continuous integration of AI and advanced imaging techniques. These innovations are set to transform healthcare by providing more accurate diagnostics, improving patient outcomes, and making imaging procedures more patient friendly. However, ethical and regulatory considerations must be addressed to ensure the safe and equitable implementation of these technology. By focusing on these aspects, the medical community can fully harness the potential of advanced medical imaging to benefit patients worldwide. These are the few conclusions we can draw. And thank you.
Thank you, sir. Any question from audience side?
Actually, we have given the what we have done in our
Yes.
advance. That is the only thing of, and there's much more future scope. R&D scope is there.
Yeah, yeah.
So if we want to integrate this basically for EEG neuroimaging devices, so this can be transported, basically translate this imaging AI to the basically battlefield or some kind of on the job, because maximum people are affected with your neurocognitive disorders,
Yes.
and some kind of changes are there in the neural structures. So if we can find out with the help of this CT scan and AI, and that technique we can integrate with this AI and FNIRS. Basically, FNIRS is similar to the fMRI, where we can find out the your oxygen content your in the tissue level. So we can find out what area is being much more affected. So this kind of challenges are there, and this is a basically research gap is there. We can fill in the research and development area. I
So,
think yes, ma'am. I think no more questions. No questions is there. So this is a either they understood well or either they couldn't understand maybe.
no, thank you, sir. Thank you for such an insightful and educative session on the role of machine learning on medical imaging. It was truly enriching.
Thank you, ma'am.
I request everyone to please switch on their cameras for a group photo session. Everyone, please switch on their cameras. So, we are getting the messages. The participants actually found it very informative. Your session was brilliant.
Thank you, ma'am. So nice of you. Because I am very happy to see this kind of audience because your FDP, your continuous learning program is there, obviously.
Yes, yes, sir. Sir, participants are asking if, in case you can share your PPT also.
I will mail them. No, I will mail to you and then
Yes,
you can
yes,
share.
ma'am. You can ask. Yeah, sir. One question is there from audience.
Okay.
I
Hello.
wanted to ask, hello,
Yes.
are you able to hear, sir?
Yes.
Sir, I wanted to ask that can we use AI techniques like here you were talking about brain segmentation. So how
Yes.
about the cardiac segmentation? What are the gaps that we can still find out in cardiac image segmentation using MRI images?
Okay. Actually, cardiac generally what we do, we have our angioscintigraphy is there. Then we can multimodal fusion with the help. What happens now? Whenever you have find out any specific problem, then we have to take all the images with the every modalities. Then with the sync, we can find out what kind of voxel or what kind of box we have to design for the to cover that kind of area. That
Sir, you were
imaging.
talking about a YOLO software. So I was asking that can we
Okay.
use it YOLO in cardiac image segmentation as well?
Madam, we can use, but this is like basically a trial and error kind of thing experiment. So if we find out with the normal deep learning methods or your FRNR, CNN, it gives better result or this gives better result. This is basically, I mean, nobody has done, maybe it's still not reported, I think. So This
So
is
that's
a
what I was asking, sir. Like we can use RN and
we can use,
CNN.
we can try this. We can try this
So we can
because
try it with YOLO, so we can maybe we can get a better
yes, yes,
impact.
yes,
Yes.
yes, yes, yes. Now
So
the
we can
version
have
YOLO
a
8 is there. YOLO 8 is there, so you can have more number of options are there. You can find
so
out much more
I
easily.
was actually I don't know about YOLO. So is it a software which is
It is a
there?
framework, madam. It is a framework with the CNN framework. Yes.
Okay. So is it available
Ha, it is available. Free tool is available. No issue. You can
free
download.
tool? Yes. Okay.
Yes.
Okay. Thank you so much, sir. Thank you for the query, answering query. Thank you.
Hello.
Yes, ma'am.
So my question is, like nowadays we see various topics like detection of particular disease using MRI, and that
Yeah.
too like early detection of that disease. Okay,
Yes.
so can you explain how we can identify or how you can find out that this is a early detection? Like through the symptoms, it is a one way, but uh, I don't know what could be the different ways to identify. Yes, the person is suffering from this disease. He is in a early phase of that particular disease.
What happens, madam? Actually, your question is very good because the detection is a very challenging task, and nobody offers for any kind of screening also. So, if there is something marker is there, for example, just that's why I talked about like EEG kind of thing, which is non-painful. If it gives some kind of alarm, some kind of screening marker is there, then we can go for the basically deep investigation. So we have to find out the markers in the pre-markers. Basically, whenever the disease is there, for example, we have a MRI scan of the normal healthy human being, and then we have some kind of marker. Basically the data set that should be the different stages of the basically the disease should be with us in the data set. So we can have different markers which we can correlate in the earlier basically as early we can detect. So
Uh,
for example,
Markers,
if
sir.
yes, madam.
Markers. What could be the different markers?
Markers, for example, like some kind of anxiety is there, some kind of stress level is increasing, some kind of correlation is there with the EEG. Then we can
Okay.
go in the details, some kind of basically neural structure has been changed, or what is the reason for this. Then MRI can give you better detail, which kind of your structure is being changed, or it may be from any reason. Maybe the person has some kind of trauma or some kind of accident or some kind of something is there. So if in case of healthy, there is always a problem to identify. It is a very challenging task because in our case in government, what we do, we generally do screening for in every year. So it depends upon the person if he is maintained for the specific task or doing specific work. If you want to analyze basically your brain neuroimaging, you want to check your heart health. So they are the basically few things prescribed in the medical domain. These are the few markers or few things which we have to check. If there is something variation is there, then can go for this
Okay,
detail.
but like generally in case of a medical field, we cannot directly talk to that person, or we cannot have the direct communication with that person who is suffering from that particular disease.
Yes,
So
yes,
consider now we have only image data set like MRI data set,
yes.
and from that it is not feasible to identify the markers, right?
Actually, madam, marker is a long process. Basically, when you have a good data set and we have a good your domain knowledge, then you can easily find out. Then you can not easily. It is a very basically it is a marker. Finding marker is a long job. So when you have all variety of possible combination of all or different stages of data set is there, then only you can make a marker because making marker is a long process.
Okay, one more thing is that, sir, suppose I have downloaded a data set from the Kaggle. Now, in that
Yes.
case, also it is very difficult because we don't know whether the data set of a tumor, which is in the first phase or the second phase or in the last phase.
Yes. Yes.
In
Yes.
that case, how we can do that?
No, madam, because as I told you, domain knowledge is much more important. So in mass, what we have a radiologist with us, we have doctors with us. So they tell us because they have given their requirement to design this kind of AI based some systems. Then only we could proceed. Otherwise, we were not knowing what kind of hemorrhage is there, what kind of variety of this, how to identify this. Because when you do annotations, then obviously we have to mark that kind of a specific area with a particular mapping or with a particular name. Then only with the help of clinicians we can do. Otherwise, it is not easy to do because there are so many data, fake data maybe or maybe not good. Not it is. I should not say fake, but maybe not correct data is available on net. So you have to take the help of some kind of medical practitioner. Then only you will be able to
But
understand.
these people are not like I have approached two of the hospitals and they are not ready to give their data set.
Ha,
So
madam, this is an ethical problem basically. That's why I told you, na? Because nobody wants to share the privacy of this any patient. So what we do, we take the consent of every patient and such. It is a very tough task. That's why it is not easy to design because the problem in getting the data and basically ethical clearance is very important thing. Any like Nimens is there, they do R&D. IVHAS is there, they do R&D. They are the government setup with the neurological or basically practitioners are there. They do imaging and they do some kind of modeling design also. And in mass also because only these places are there. But if some student is there, someone is coming, then we can rope in that indirect way we can do rather than directly asking for the any hospital. They will not share any data to you.
right. So with the Kaggle data set, we cannot, whatever result we get, we cannot say that this is
You
the
can
correct
take the
result for the
feel.
early detection.
Madam, actually, what you can do, you can take the feel of the existing one. Okay, how you can do this thing. This is kind of pre-training. Other when you go in basically some kind of actual model development, then obviously this is a challenge task.
Okay, sir. Okay. Thank you so much, sir.
Sir, what are the ethical and legal concern?
Medical privacy, actually, patient data you cannot share basically. There is a HIPAA guideline is there. So you have to take the consent of patient basically.
So,
Hello,
Your voice is
okay.
not coming.
voice is breaking basically.
Okay. Okay. Is it clear now, sir?
Yes, yes, yes.
Okay. Is there any real time example, sir, where this model is failed and somebody faces some legal concern, legal issues? Because there are lots of model whose efficiency is more than 99%. Still, we are not using these models in real time scenario. So
Yes,
almost models are there on on paper and
yes, yes, yes.
completing the research paper. It's still not applicable in real time cases.
Sir, I showed you the last slide, na, where ethical and your legality over that aspects were there. Whenever you design something on
Okay.
research paper, you can get published. You can take the basically some kind of recognition. That is not an issue. But when you want to translate as a real device in the field or on patient, there are so many regulatory bodies are there. We have to go through with them with that process. That is a standard process because we have to prove with the data as well as benchmark with the existing one how this is giving good result and how it is not compromising with your privacy or any legal or any issues which is already laid down procedure. So in the same way, what we say, generic medicine developed and basically medicine also when we have to go to ICMR to take all the process. So there every device which work in the AI in the health domain has to be followed with the standard practice. The basic guidelines are there. We have to follow them and we have to show them with the authentic data results. So that is a painful procedure. Matlab, it is not an easy work. So that's why maximum devices are not able to reach there because next algorithm is there. So obviously you will show some improvement result. But next algorithm which is given by some any researcher, you will give some other better result. But this will go on for the publication point of view or for research point of view. But developing a device is a very tedious job, and for getting recognition and implementation in the real life, it is a tough task.
Right, sir. Thank you so much, sir.
Any other question from audience side? I think one.
Hi,
Yeah,
sir.
ma'am. Hmm.
Sir, myself, I'm Nisha.
Yes,
I'm
ma'am.
actually pursuing my PhD in brain tumor detection using MRI images.
Yes.
Sir, where can I get a good data set for my research, sir?
Okay. From where you got this?
Sir, I'm from Atal, really.
Your voice is breaking, basically.
Yeah, ma'am.
Hello,
From which
sir.
state
Can I
you belong?
hear me?
Yes, yes.
Hello, sir. Can you hear
Yes,
me?
yes, yes. Yes, your voice is coming.
Sir, where could I get a good data set for my research, sir?
In between your voice.
Sir,
I mean,
am I
you.
audible now?
Yes.
You're audible. In between, you're audible. Sometimes the voice is not proper and it breaks.
Sir, I'm not sure where to get a good data set for my research. Could you guide me for getting a best data set for my research? Actually, I'm pursuing my PhD in brain tumor detection using MRI images.
Okay, okay. For MRI, basically, you have to all the basically neuroimaging, neuro-related hospitals. You can talk to them, and you can basically enroll with. You make them co-guide actually. Otherwise, it is not easy to take the data set. And good data set may be good or bad. It depends upon the basically how the data has been acquired. So if they have a good machine, MRI machine, and the good lab technicians are there, they will get the good data set. And then only you can take. Otherwise, it is not easy to take.
Mm. Sir, I don't have prior knowledge of brain tumor images. If suppose I get a data set from a hospital, um, is it possible to pre-process and detect the tumor from the raw data of hospitals?
No, 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 it is not easy because you will get the only basically your MRI films only. So what you have to do, you have to take the basically help with them, the medical practitioners there working there. You have to identify them. All the process basically image processing and image analysis. For image analysis, you have to take the help of those persons. Image processing you can do with the some you can see the videos and you can do that kind of some kind of basically processing. But for better result, image analysis, that you have to take the help of that medical practitioner
Okay, sir.
because it is not
Sir,
in standard shape and size available. This is the space and
yeah.
the size and the varieties always changes. And finding the volume, it is also a tough task, and find the exact location. And how this basically varies with your severity of this tumor also, I do not know exactly, but they will tell you only.
Okay, sir. Sir, which could be the early prediction? Is there any approximate time duration of the affected person's survival rate? Survival?
I'm not getting what you are asking.
Actually, sir, how could I conclude that this is an early prediction? Which could be the early prediction? Is there any approximate a lifetime duration for that affected patient?
Early detection or early prediction, I think.
Acha,
It's
early detection basically whenever देखिए nobody will go for MRI machining for healthy person. Nobody will go for screening. If there is some sign, some sign, any visual appearance is there, some kind of behavioral change is there, or some kind of basically your change in behavior is there, or some Basically, these are the markers, or these are some kind of basically trigger you need for this. Some symptom you need that. For some symptom, you need much more domain knowledge of that. Then only you will be able to find out. There's no basically like any radiation or any radiation source which change the wavelength for any spectroscopy or anything which changes the. But that kind of exposure can be done only for your blood sample or urine sample. These can be done. If there is something related with your blood or urine or some kind of sample, that may be helpful. Basically, you can get this information with the medical practitioner, how they some kind of changes in the body. If there is some tumor is there, what kind of changes are happening in the basically your anatomy, or what should I say, blood or urine or any basically skin. Then
There
you can
might
only.
be a reflection in that. Okay. Okay, sir.
That may be
Sir,
the.
also,
I'm not sure, but that may be
uh,
the.
okay, sir. Sir, may I know the main difference between the CNN and the RCNN?
Basically, this is a method. Basically, you already redefined your area, relocalized that area, that kind of post-processing kind of thing. So when you give the more information for CNN and you fix the basically the reason where you want to use this, so that called these are the basically some kind of modification the CNN, and these are the fancy names which has been appearing in the variety of basically CNN algorithms.
Sir, uh, sir, um, in which place I want to use the YOLO framework,
Okay.
where it is getting used.
For object detection, if you want multiple object detection or basically variety of objects in one pass, basically you have a CNN. This is a CNN based only, but it gives in one pass all the information rather than multiple iterations. So this is much more fast. It takes more frames per second. But for any application, deliberately we cannot say ki this is much better, this is not better. You have to try two or three algorithms, then you can find out maybe the data set which is available and the basically object uh, uh, you have to take check two or three algorithms, then you have to find out the optimized one for your application.
Yes, sir.
But this is one of the
Uh,
option.
really,
This is one of the CNN option available, and you can try this because these are the models already designed. You have to put your inputs and you have to check this. So you can try two or three options also, RCNN also. So if it gives much more better, then maybe it is slow, but it may give the better result also. No issue.
yes, sir. Actually, I have given my research work in GBN and CNN, Deep
Okay,
Gulf
okay.
Network and CNN. Is this
Okay.
wise choice, sir?
No, wise choice only gives you if you use YOLO and it gives the bad result, then obviously your choice is good. If it gives if YOLO gives good result, obviously you can change your algorithms. Because research is a part of the basically your PhD or research work is always is exploratory. I mean, always you are always looking at better results, so you can modify this.
Okay. Sir, if I'm not getting the better accuracy, then from which part I have to refine my model, sir?
Madam, actually you have to take
From like segmentation or from
yes, segmentation or your registration are most important parts. You have to modify them. You have to try and error. This is a trial and error game, basically. You cannot get in one thing one shot. So obviously you have to improve and you have to model. And you maybe at the time your YOLO 8 or YOLO 9 may also come because these are fast changing models. You can try your latest one because you have to compare with your latest one, and it is an iteration based system only. You just try and just take the feedback and what can be changed. There's no set rules in R&D, and that's why one sir asked why the things are not available in the market. So whenever you say this is not good, this is I am getting better result, and I am getting this better result. So always there is changing atmosphere. So it is not easy to translate the thing in real world.
Okay, sir.
Okay,
Okay, sir.
ma'am.
Thank you so much, sir.
Yes, any other question from audience side, if you want to ask any? Yes, Anuba ma'am, you can continue.
Thank you so much, sir, for being so patient in addressing to all the queries. You answered it brilliantly. Thank you so much.
Thank you, ma'am. So nice of you
Can I
being there.
once again ask all the participants to please switch on their cameras for a group photo?
They all are in the homes and they are in the rest position, so nobody is switching on the basically.
Everyone, please switch on their cameras for a while.
Anubha ma'am, the screen share has to stop for the group photograph.
Oh, so Rajesh sir, you will have to
Yes.
stop the screen share. Yeah.
Okay.
Thank you so much, sir.
Okay, ma'am, it's done.
Okay. So, moving on, it is my pleasure to welcome our second speaker for the day, Dr. Rajesh Prabhakar Kaila. Dr. Rajesh Prabhakar has over 21 years of experience in big data analytics, specializing in tools like R, Python, SAS, PySpark, MS Excel, and SPSS. He is currently the founder and CEO of Data Advance R Labs, a specialized consulting firm in strategic data management, IoT, and fintech. Dr. Rajesh is also an accomplished corporate trainer and visiting faculty, conducting training programs, workshops, and executive education programs for prestigious institutions like NMIMS Mumbai, SIBM Hyderabad, and BITS Hyderabad. He has worked with prominent clients including HSBC, Societe Generale, SBI, Wells Fargo, and CGI. We welcome you, sir.
Thank you for your introduction, ma'am. My voice is clear?
Yes, voice is clear.
Yes, sir.
So please switch on your camera so that.
Yeah, yes.
So you may share your screen with the PPT.
Yes, it's visible.
So as I requested, as a precursor, participants to have a Kaggle account with mobile verified, they can access the what you call the GPUs and all.
Yes, sir. I
If you
think
have access, it's
we
okay.
are
Otherwise,
confirming for, we are giving one more minute. If they are not uh, sign up their account so that they are sign up their account and sign in through this Kaggle.
Yeah, so I'm pasting the link of the what you call the data set which we are going to use. CT scan lesion data set which is there. We will be using this data set.
Any of the participant having any problem, then you may ask. I think all of them are sign up through this Google.
So you can, I have pasted the link in the what you call the chat. You can click on the link and there is an option called new notebook. On top, you can see there is a new notebook option. You can directly click on this new notebook. You will be able to access the data directly in the new notebook. So just click on the link which I have sent in the chat. All of you can access the link which has been sent on the chat. And then once you get the link, you can see there is an option called new notebook. You can click on this new notebook. And once you click on the new notebook, you will get the access to data. Okay, can I move forward, participants?
Yes, sir.
So just wait.
Yeah.
Participants write in
So
chat.
I could log into Google, but
Yes, anyone can ask. Yeah.
So once you log into Kaggle, you can see there is an arrow on the bottom down side of the screen. You can click on that expand sidebar. And then if you scroll down accelerator, you can choose GPU T42. Turn on the GPU. So on the right side, you can see there is a screen here. You can see there is a window icon. If you scroll down, you can see the data set here, the frames and the mass data set. And if you go down session options, accelerator, you have to say T4 GPU. So Kaggle provides you with 2 GPUs, which you can use for your neural network based learning, because neural nets require graphical processing units.
Excuse me, sir.
Yes, please.
Sir, I have one doubt that in the session option, I got only 2 options. That is, one is Python and R.
Where in session options.
Yes, sir.
That means you have not verified your mobile phone. You have to go to profile and verify your mobile phone. Then only the GPUs will be activated. So just
Okay,
click
sir.
on your profile and verify your mobile phone. It just take 30 seconds. A 6-digit code will come. Just activate the code. It will get access to the what you call the GPUs.
Okay, sir. Thank you.
Okay, I will start the session. Meanwhile, anyway, initially we'll be discussing the
sir,
theory. All of you can click
I
on
could log
the
into the
link.
Kaggle, but I'm able to get the database.
So you have to click on the link which I sent in the chat. Don't open Kaggle. I have sent you the link of the data set.
Okay, let me check.
I am sending it again.
Okay.
Because the data is fairly large. So what I am doing is I am sending the data set link in the chat. Click on that link, you'll get access, and then on top you'll see new notebook. Next to download, you will see new notebook. The data is a very large data set. Please do not download it, and uploading it will take time. So what I would suggest is there is this new notebook option is there. Click on the new notebook. The data will be automatically there. Don't download the data set. Please click on the new notebook option. And then you will see the data set already there.
Sir, can you can you explain, sir, how to register that it is not coming, sir?
Okay, you have to go to your profile, ma'am. Home tab, click on home. There will be, or
Yes,
if you scroll down, you will have an account, home tab only. Click on home.
yes, yes, sir.
On right side, you will see a what you call an icon with the duck symbol,
Yes,
right
sir.
side top corner, and then you click on your profile or click on settings. There, I think you have to do click on settings and do phone verification.
Okay,
On the
okay,
right
sir.
side, you will see a duck icon. Click on it, and then there is something called phone verification. Until you verify your phone, you will not get access to the GPUs.
Okay, okay, sir.
Just it will take 10 seconds. An SMS will be sent. That's all.
Okay, sir. Thank you. Done.
Then you will get the data as well as you will get the access to the what you call the notebook. On the right side, the data will be automatically there. And then if you scroll down in the input, you will see session options. Accelerator will be there. Then click on GPU T42. And whoever has done this, just run the first cell. Go to anywhere on the cell. Just there is a run option here on the left side, or shift plus enter. The keyboard shortcut is shift plus enter. You can put your cursor anywhere in the cell. In the first cell which you see here, this Python 3 environment, import numpy, np and all. Click anywhere on the cell, shift plus enter, the keyboard shortcut. It will import the data. So today we will discuss medical image segmentation. So there are two things you can do on medical images. One is the classification part. The second is the segmentation part. So all of you can see the font size on my screen. Is that clear? So medical image segmentation is used when pixel level predictions need to be generated. So when you have pixel level predictions, pixels level predictions within the image. So you all know within an image there are many pixels, and pixel level image predictions are to be generated. Then we use medical image segmentation. Now, medical image classification is where you classify the total image. Image as a whole is classified. So that is the basic difference between medical image segmentation and medical image classification. Now, medical image segmentation is used when when there is a requirement for locating specific areas of an image like tumors, lesions, etc. So what this medical image segmentation will do, each pixel will be labeled.
Sir, excuse me. Sorry to interrupt, sir. From the beginning, can you just start? Because here we are not getting the exactly that we are getting in the top HDD, CPU, RAM, GPU, and all that. I'm not getting.
That will get only if you activate the GPU. Then
Hello.
you have to activate that you have to activate the session options GPU. Did you do the mobile verification?
Yes, sir. Yes, sir. I've done that.
And then once you clicked on the link which I sent in the chat,
Yes, yes, sir.
a new
Then I
notebook you
got.
have clicked. Did you click on new notebook?
Sir, I got that COVID-19 CT scan lesion image. Then after that, new notebook in the right hand side, I
You
press
click
that
on
one.
it. Yeah, click on new notebook.
Yes.
It will open a new
Yeah.
notebook. And
Yes,
it will
sir.
automatically give you the data sets and the output. On
Yes,
the
sir.
left side, you can see, right, there is a input option.
Accelerator. So here I have to press GPU.
T42.
Okay. And the other two are for TPU and GPU P100.
No, they are not relevant. They are old. TPUs is not used. GPU, that is the old version of GPU. This is the two GPUs which are provided. T4 GPUs is the latest version.
But accelerator I cannot find. Accelerator.
That only find if you verify your mobile. If you
I
have
did
not done
that
your mobile
already.
verification,
I did that. I could open the new notebook and the code. Now where to find the accelerator?
session options,
I could
scroll down.
see this accelerator, but the data set I'm unable to fetch.
You have to click on
Session
the link which I sent in the chat.
The new net.
Session options are not coming, sir. Where is the session option tab?
Scroll down. If you scroll down, you will see session options on the left side. See here, you have to, your screen might have been closed. Click on there is a bottom down, there is an arrow. Left side, right side.
So that is
Expand
activated for 30 hours. It is given.
Yeah.
Okay.
Maximum 40 hours is what you get.
Okay. Okay. Or weekly or month.
Sir, I can find your work, but not the session options in the left side. Here is home competitions, models, code discussions.
This is the link which I have sent. You got a
Yeah,
link, new notebook.
I opened the link, the new notebook. I opened notebook
On the right
684C.
side, do you see input?
Right side, I add input and upload.
Paid
Below
input, yeah.
scroll down, you will see session options. Below table of contents.
Okay, below the table of contents. There are no sessions detected.
Yes.
Yeah,
Session option
session
is
option.
there.
That means refresh your thing. Your account is still not verified.
Okay, sir. Session options I got
Turn
in
on GPU.
accelerator.
GPU T42.
Okay, turn on GPU.
Right.
Persist and everything is same, persistence and environment.
Rest of all are same except accelerate GPU T42. Please do not change any other options.
Okay, sir. Thank you so
Then we have
much.
to save it,
And so
sir.
what about
No, it will automatically activate. No saving. Just you can close
Okay,
the
sir.
side, collapse the sidebar. On top, once you run the first cell, then your GPU and all will be activated. Just come to the first cell, press Shift plus Enter, or you can see there is a run icon on the left side. Click on the run.
Yes. Okay, sir.
Then you
It
will
is
see
giving
all the
session
images.
started.
Yeah, session started. Yes.
Okay.
It will say session started. Then on the draft session, you will see the GPU, HPU, all those things will be there. GPUs will be activated.
We should press run
Got it,
current
got it.
cell.
Got it.
Don't press anything, ma'am. Just run the first cell.
It's written run current cell or run all. So
click on the cell and use Shift plus Enter. Or you can say run all because this is the only cell you have in your notebook as of now.
okay. Run all. Okay.
First cell, if you run using Shift plus Enter, you will get all the images imported into the Kaggle environment. Okay. Can I move forward?
Yes.
Yes, sir.
So, medical image segmentation is for pixel level predictions to identify tumors, regions of interest within an image. So, each pixel will be labeled, and this is used in MRI scans, X-rays. So, commonly used in MRI scans, X-rays, other medical images. So medical segmentation, image segmentation is different from classification. So image segmentation is designed to identify regions of interest in a particular image, like tumors and lesions, or what you call inflammations in the medical image. You can identify using these image segmentation models. Now, one of the popular image segmentation model which is widely used is UNet. So if you are looking at the widely used model, image segmentation model is UNet, the base model UNet, or let me put a hyphen, U-net. So UNet is a convolution neural network. It's a CNN only. It's a convolutional neural network. Don't worry, I will share all these notes in both PDF format and IPNB file format at the end of the session. So if you are not comfortable with typing, just write a pen and paper notes. I will share every notes and everything, whatever is there here, as a PDF format as well as an IPNB file format, the Python file format at the end of the session. Okay, so UNet is a convolutional neural network model, CNN model only, specifically designed for medical imaging Now, if it is a typical convolution neural network, I believe most of you might be familiar with a typical convolution neural network, right? If you are familiar with the typical convolutional neural network, you have convolution layers at the beginning. That convolution layers will work on the image. They process the image along with the pooling layers. If you look at this image here, you have a convolution layer that takes the image as an input, and then it applies a filter, a Sobel filter or any other kernel filters on that image data, and using activation functions like ReLU, it reduces the dimensions of the image without losing any information. Pooling layers also further reduce the dimensions of the image without losing the information. And finally, the information which is gathered from the convolution layers will be passed down, will be flattened into a single vector array, and then it will be passed into a neural network model. So this is a typical convolution neural network model which we use for image classification. But when we talk about UNet, that's a different version. So UNet has a different version because it is designed to work with medical segmentation. So the UNet comes with something called encoder and a decoder model. UNet is a different version type of model. If you look at this structure here, there are convolution layers, but the convolution layers here work in a different manner. The convolution layers will act as encoders and decoders of the model. So the UNet model is slightly different compared to your normal, what you call image, what we use for typical it's a classification model. So just let me paste the image architecture so that can have. So this is a typical what you call architecture of a UNet model, where you have convolution layer, 3x3 convolution layers, and then you have pooling layers. 1 second. So the red ones are the max pool layers, then your upsampling and downsampling layers. So I will explain to you what these layers do in detail. So, but for our understanding, UNet is a convolution neural network based architecture only, designed for image segmentation. The key components of UNet are: first one is encoder. Encoder reduces spatial dimension. Encoders will reduce the spatial dimension through convolution and pooling. Through convolution and pooling, it will reduce the spatial dimensions. Then you will have bottleneck. The bottleneck captures the most abstract features of the input, captures the most abstract features of input. And then we will have a decoder. Upsamples the feature maps to original input size and the output layer. So a one channel output using sigmoid or softmax activation functions. So sigmoid is used for binary classification, softmax is used for multinomial classification. So these are the components of your UNet model. There will be encoder, there is a bottleneck, then there is a decoder model, which will convert the data back to your normal original input state. So if you see the visualization which I pasted here in the down, so this is your encoder. Here you have a bottleneck, and then there is this is your decoder component. So you have a bottleneck means it will compress the network, and only most abstract or the relevant features will be taken into consideration. So this is the basic concept behind the UNet, or the one which is based on convolution neural network designed for image segmentations. All right, participants, all of you are in the what you call data. All of you got the data?
Yes.
So the process here involved is we have to follow certain processes which is to be done before we start working on the data. Typically, we have to do pre-processing activities. If you are looking at pre-processing to be done before implementing UNet. One, resizing. So resizing of images. Typically, we use the rule of 2, like 128 by 128. We don't go beyond below 128 by 125, 256 or by 256, or maximum 512 by 512. But 512 by 512 will need a lot of computing power. Preferred are these two, 128 and 256 are the preferred resizing pixels that we use in working with large scale image data. Either 128 or 256 are preferred. 512 will require a lot of computational power. The GPUs might crash. So we have to do resizing. The second step we have to do is.
Sorry to
Yes.
interrupt you, sir.
Yeah.
Sir, as you said, 128 is the default size that we can take. But what we are dealing with some different framework like ZNet or the exception or Inception model or the resonate model. So at that time also we can use the 128 by 128.
Any image classification or segmentation, when you are dealing with images, the preferred will be 128 by 128 or 256 by 256. If you have processing power, you can go with 512 by 512. See, this is what you call pixels, right? So if you have, let us say, a 28 by 28 image, 28 into 28, how much? 784. The matrix size will be 784 elements will be there in the matrix. If you have a small image of 28 by 28, how many value? 28 into 28 means what? 28 rows and 28 columns. The matrix, each image matrix size will be 784 elements. Here already we are giving 128 by 128, which is a very large scale image thing, which a GPU can handle. CPUs can handle 28 by 28 images, not the large scale images. So GPUs are designed to work with large scale images. So we can deal with such large scale modeling. So 128 by 128 means you will get a very large scale matrix. 128 will be thousands, right? 128 by 128 is how much? So it will be somewhere around the matrix size for each element would be 16,384. The elements will be 16,384. So that is a very large matrix, right?
Right, sir.
So I think day after tomorrow, there is another session of mine where I'll do transfer learning, where I'll run ResNet, MobileNet and InceptionNet and all.
Okay, sir. Thank you.
So normalization or min-max scaling has to be done. So normalization or min-max scaling will scale data into a range of 0 to 1 and only positive values. So min-max scaling will further reduce the data size. We can, one of the common pre-processing for all images we do is we do min-max scaling. We don't do standard scaling and any other scaling because they will generate negative values. And in image processing, we do not want negative values. So we want only positive values, min-max scaling. Is that clear? So normalization or min-max scaling, scale data into range of 0 to 1 and only positive values. We also need to do augmentation. So image augmentation like rotating, flipping, scaling, etc. has to be done. So image augmentation also has to be done. Then one important for image segmentation is mask processing. So mask processing is segmentation marks or annotations are processed either as binary or multinomial. So mask processing is there. you have to do segmentation mask. So these are the basic pre-processing which you need to do for any image processing. So here also for unit also we have to do this basic image processing.
Sir, what exactly we do with the mask processing? Why we use it?
So mask processing is where we have to create mask images. So if you look on the right side, the original image will also have some masked regions in the images. So that it can, these are your frames are your original images. If you click on this original image, you can see the image, right? All of you can see the image.
Yes, sir.
So similarly, click on the masks. You can close this image and then click on the masked image. You can see that some regions of the image have been covered. So all of you can see the difference between the original image and the masked image, participants?
Yes, sir.
Yes, sir.
So these masked images are those images which are particular regions are covered up, so that the algorithm will take it as a challenge for predicting the, because we are doing pixel level predictions here, not as a whole image. We are looking at pixel level predictions. That is why we need to do this masking of these images. So this is one of the major difference for an image classification and image segmentation activity. All
Good
right. All of
evening,
you
sir.
got it? Yes, please.
Sir, I am Disha Moini Pathak from ABS Engineering College. I have a small query regarding segmentation.
Yes, please.
Sir, let's say we have taken a CT image of lungs, and
Mhm.
as it is shown in the lungs, the internal means tumor part. So it is actually when we are segmenting it, or it is making a mask with tumors only. Means in between the tumors, it is actually giving those segmentation mask. Let's say if I want to make a mask that will cover a whole actually lung.
Okay.
So let's say I have created one GT, and in that GT I have created the whole covered the whole lung. But when I predicted it, or when I trained my model gives me the mask with the tumors by segmenting the tumors. I hope you're getting what I'm saying.
Yes. So what happens is the regions of interest is there when you're masking these images. You have separate softwares for masking these images. So uh, those masking of the images can be done based on your requirement. Which regions of interest you want to mask, those regions of interest you can mask. Not that there will be only fixed regions will be masked. So you can choose. There are softwares, there are methodologies available for
Okay.
conducting a masking of those images.
Okay. Let's say if I created my own means own code for creating a GT, but when I predicted it, it is actually giving me not it is not giving me the covering the whole organ. It is giving the mask of a tumor, and that is the error which I am getting in my code.
Okay.
So actually I want a mask
means I have trained my model, segmentation model, for a
Mhm.
mask that will cover the whole lung. But when it is giving me the prediction, it is actually giving the mask that covers only the tumor part. It representing me the tumor part. It is not giving me the mask that cover the whole organ.
But if you can't cover the whole organ, the masking concept is only specific regions of the image can only be masked.
No, I just want to actually segment the lung part.
You are taking only lung X-ray or lung CT scan, right?
Lung CT scan.
Okay.
So
So
is
you
it
have to see masking is a different thing. So as you can see here, that is why I've asked you to see the images. You can see different images here. They are not original only one mask. You can click on different types of images. So you can see different regions of the images will be masked.
yes, yes.
So when you're masking the data, when you're creating such masking data, you have to make sure the masking is done on different parts of the organ, not on a single location.
Okay.
So that means you have to create masks that highlight the tumor regions as well as the non-tumor regions.
Okay.
Or I'll explain to you once this thing is there, because this is a specific issue.
Yeah, sure.
I'll
Thank you so
respond to
much.
it. So masking is a challenging task. Masking has to be done for your original own data sets. It's a complex procedure which needs to be done with a lot of this thing. So based on that only we can work on that mask data.
Yes.
Okay.
Thank you, sir. Thank you, sir.
So these pre-processing activities have to be done before we do any sort of analysis. So if you look at the unit model, as you can see here, which in the architecture and all, the model which we are going to build will be a simplistic model, which will have both path encoder as well as the bottleneck. So based on that, you will be able to understand how this whole thing will run. Just let me access the code book. So we are importing the data here. So I'm pasting this code in the chat also. You can take it from there. I've pasted the code in the chat also. You can copy and paste it into a new cell in the notebook. Now, what you have to do is you have to change the paths here. The image folder paths, you have to change to the folder paths of your Kaggle. So if you go to the right side windows, if you move on to the frames icon, there is this two square bracket icon will come. Click on it. It will say copied. And then below it, you also see the mask. So on the right side in the data sets, you will see the mask. So you have to change the paths to your Kaggle folders. So just change the mask path. So we are using the operating OS library to get the paths, then NumPy to process, and then we are using the predefined functions load image and image to array. Just change these two paths to the Kaggle, what you call to the dataset folders which you have in your Kaggle on the right side. And as you can see here, we are listing the paths and then we are pre-processing here. So the pre-processing here is we are converting the images to 120 by 128 grayscale images. So we are converting the pre-processing here. We are converting the data to 128 grayscale images, and we are also dividing by 255. So min max scaling 255 because the min pixel will be 0, max pixel will be 255. So that is why we are normalizing the data into here in this part. So here we have to set up the paths. We are getting the paths to the folders. Then we are doing the pre-processing here. So this part of the code which you see here, we are doing the target size as 120 by 128 and grayscale conversion. And below we are doing the normalization because min pixel is 0, max pixel is 255. So you are dividing it by 255, you are normalizing the image. Then we are converting into NumPy arrays because the matrix format, or we use the data into a matrix format. And then we are splitting the data into trained data and validated data with test data size being 20%, 80% being the trained data size. So this part of code which you see here is doing the complete pre-processing of the images which we are getting here. So we are getting the paths. I believe all of you are changed the paths, right? So the paths need to be changed to the folder. So on the right side, if you expand the window, just hover around on the frames, you will see right side, two square brackets icon, click on it. It will say copy the pad.
Sir,
And
do
then,
we take a new notebook?
no, we are
Do we
doing on
take
the
a
same
new?
notebook where we got the images.
Yeah, under below that code, we should paste this, which we have written in
Yes.
the right side.
Yes. On the top, you have got the images, right?
No, I on the top I've got that the
That's a
links
cell.
of the images maybe. Yeah, links like input COVID CT scan lesion and many images like this, not the images.
No, images will not come, ma'am. Only the paths will come.
Yeah, the paths have come. So I press
After
code.
that, you have to add a cell. After that, you add a cell. You can
Add a
click
cell,
the
okay.
plus sign, or you can click on the plus sign on the left side. There is an add cell thing, or by default
Yes.
there will be a cell added at the bottom.
Yes, ma'am.
In
And
the
then I
bottom.
paste the code.
Then I paste the body.
Okay. Okay, sir. And then how to run this, sir?
Shift plus enter.
Shift plus enter. Okay.
So participants, it will just take little bit time to run. So let the cell run because the data is very large data. It will take time to run the data file.
Sir, you were telling something about frames. Can you please repeat that part?
So on the right side, you will see the data sets have two folders. There is a subfolder. If you look at the data hierarchy, the data set has two folders, the frames folder and the masks folder. Under the frames, you have, if you move the cursor on frames, you will see there is a two box icon coming. Click on it. That is the path, copy path icon.
Frames has some files. Yes, you have to right click on that.
Don't click on the things. Just move your cursor on frames.
Yes, sir, on frames.
Right. Then you see on the right side, there is a two box icon coming or the copy icon coming. You can see on my screen.
Yes.
Just click on the two box icon or the copy icon. It will
Okay,
copy the
okay,
path.
okay, okay. It will copy
And
the
paste the path here.
Sir, where to paste? Please repeat. Just a second. Where to paste?
In the code cell, you have image folder and mask folder.
Yeah, in the image folder and mask folder. Where we have to paste?
Codes and the path. Change the path to your folders.
Okay. Just a second, sir. I'll try. I'm not getting that two squares now. The screen is. Sir, I think I'm not able to see that thing.
The
here.
voice is not audible. I think someone mic is on.
I'm audible now?
Yes, sir, you are audible.
Yeah. So for all of the participants it ran. Anybody is having any problem, you can give me your AnyDesk number. I'll help you out. So there is this AnyDesk, which is a small software. You can install it, AnyDesk, and give me the 10-digit number. I can remotely access your system and help you out. For any errors and all, you can give me the AnyDesk number. I'll access remotely your system and then solve your problem. So this is how I believe all of you got the data, right? Once you see the number, if it is still running on the right side, means it is left side. If you see here on my screen, if this cell does not have a number and it is still running, means wait, please do not interfere with the cell. Let it import the data. Once the data is imported, you can see the number here in the cell, which means the data has been successfully imported. Okay. So after importing the data, we will define our unit model. So the unit model which we are going to use I think I lost the model. 1 second. So I'm pasting this model also in the chat. You can take it from there. So we are using TensorFlow here, the convolution 2D TensorFlow library we are using, because TensorFlow is supported by Google and it has a production level what you call functions, predefined functions for building our own neural networks. It is a simpler library to use compared to PyTorch. PyTorch requires a little bit of programming knowledge and all. So here we are using what you call TensorFlow, Google TensorFlow. TensorFlow is run and operated by Google. So we are going to use TensorFlow functions here, which are easy to use. It required less syntax also compared to PyTorch. So if you see here, we are importing the required functions and the required ones. So from from TensorFlow.keras import layers and models. So we are defining the unit model here. This unit model which I am using is a predefined model, with, you can see here, the encoder path comes up with convolution layers. You can see here, this is the encoder path, which will extract information from the images which you are getting and do downsampling. That means it constantly reduces the dimension or the size of the images to a smaller level. So if you see here, convolution 2D, 64, 3x3 kernel, activation ReLU, padding is same. Padding same means a layer of zeros will be added next to the surrounding the convolution layer for edge detection. So a layer of zeros will be added. Padding is equal to same means a layer of zeros will be added surrounding the image for efficient edge detection. The second layer is also 64 unit 3x3 kernel, activation ReLU. ReLU is the preferred activation in image processing because it does not have negative values. The ReLU function is max of 0, z, where if it is negative value, it will be assigned 0. So in the ReLU activation, all the values will be positive. If it is any negative value, it will automatically convert them into 0. The weights might become negative, so it will convert them into zeros. And if it is a positive value, it will retain the positive value. So this is the encoder one, where we have defined convolution 2D, 64, 128, and 256, 3x3 kernel, activation ReLU with padding. Then we have defined a bottleneck, convolution 512, 2 layers. And then we have done the decoder, the expansive part, where we have used convolution 2D transpose to transpose the matrix, concatenate it. We are doing the upsampling here by transposing the matrix, and then we are defining further layers. So this is a predefined model which I am using. So output layer, which is which we have here, activation is sigmoid because we are doing a binary class prediction. So this is the definition of the model, which is a predefined unit model I am using here. So for your understanding, we have expanded the model here. You can just copy paste the model and shift enter, run the model. So the encoder path, this is the encoder part of the model, convolution layers. Then you have the bottleneck, and then the expansive part of the decoder, converting data back to original input size so that the predictions can be generated. So encoder, decoder, and the what you call bottleneck, the three components that are required for image segmentation. All of you got the model? Can you guys confirm?
Sir, I am not able even to run the upper one code. The upper code is not running, although we have pasted the destination and mask and
Give me your
folder.
AnyDesk number, ma'am. I'll check your system. Just give me your AnyDesk number. AnyDesk is a very small software. Just install AnyDesk.
Okay,
and give
okay,
me your
sir.
10-digit number. I'll correct your system.
Okay, sir. I try.
Put it in the chat. I'll access your system and I'll help you out. Any other person is having issues, you can also give me your AnyDesk number. I'll correct the problem on your Kaggle notebooks. Now, after defining the model, we need to compile the model. For every neural network, we need to give the optimizer or the gradient descent. We have to define the optimizer. Adaptive momentum descent. By default, most of the neural networks are using adaptive momentum descent. It is a type of descent algorithm that is used to do the weight adjustments in the backward propagation part in a neural network. And the loss is binary cross entropy. We are using, if you're doing multinomial prediction, this will be categorical cross entropy, the loss function. If you remember, loss function will be every algorithm has its own loss function. So then the matrix is accuracy. So confusion matrix accuracy is what we are going to use. And the model summary will also be there. Forgot the model summary. So model dot summary. So if you do the model summary here, I'm pasting this code also in the chat. You can take it from there. So we have in our model 85 lakhs 56,353 weights. So the model has 85 lakh 56,353 weights. So this many weights need to be adjusted in the model. So this is a very, very large model, complex model with 85 lakh 56,353 weights. So if you are wondering what these neural network weights are, for every neural network, at the beginning, we will have random generation of weights. So for every neural network, at the beginning, there will be random generation of weights based on the number of neurons that we have in our network. Right? All of you are familiar with neural network, right?
Sir, I have shared the ANIDAS number. Can you please help me?
Yeah. Yeah, so I'll help you, ma'am, just a second. So if you are looking at a neural network, like if you see my screen, you have, let us say, two inputs and three neurons, one hidden layer and one output. Let us say I have two independent variables, x1, x2, and a dependent variable y. So I have data like this. So these are the observations we have in our data. Two independent variables and one dependent variable, which is a binary variable, 0 or 1. So let us say I am modeling for this set of data. You have x1, x2, which is 1 and 1, 0. So what neural networks typically do is, this is the hidden layer with 3 neurons. This is the hidden layer with 3 neurons. So you have 3 neurons in one hidden layer. So the input goes through every neuron. The input has to go through every neuron in the network. The input will go through every neuron in the network. So here, and the output also will receive information from every neuron in the network. So this is your input layer, this is your output layer, and this is your hidden layer. So random weight generation. So for every connector, there will be a weight 0.8, 0.4, 0.3, 0.2, 0.9, 0.5, 0.3, 0.5, 0.9. So we have 9 connectors, 9 weights are initiated. These are randomly initiated at the beginning of the algorithm, and during backward propagation, these 9 weights will be adjusted. So you have 9 connectors, 9 weights. So in our unit model, which I built, we have such weights, 85 lakh 56,000 weights. So 85 lakh 56,353 weights are there in our unit model, which I have initiated, which itself will tell you how large this network is. So 9 weights we see here in this calculation. So if you are looking at backward propagation, all the 9 weights must be adjusted. So in backward propagation, all 9 weights must be adjusted. You cannot ignore even single weight. Right. So the backward propagation must adjust all the weights. So like this, in our unit, all these weights are adjusted. 8,56,000 weights will be adjusted for. And How the weight adjustment is done? It is based on the gradient descent algorithm. If you look at this, you have iterations, you have the error, and what the descent algorithm says, reduce weights in smaller proportions over multiple iterations. So gradient descent says reduce weights in smaller proportions over multiple iterations. So one of the type of gradient descent which we are using is ADAM. ADAM means adaptive momentum descent. It's a type of gradient descent, or what we call optimizer. So optimizer will make sure how the weights have to be reduced, in what proportions the weight needs to be reduced, such that the error can be minimized. Error cannot be made zero, error can only be minimized to a certain extent. This optimizer will take care of this weight adjustments, at what proportions the weight should be reduced, and how we should reach our lowest minimum point. So one type of gradient descent we are using is ADAM, which is predefined, widely used in industry, which is a fast one. ADAM means adaptive momentum descent. So adaptive momentum descent. It adapts the descent calculations based on the values. So this is what we are using, adaptive momentum descent. So these fundamental concepts, you need to understand the importance of weights in a network and what optimizer, the role played by optimizers. And in case of segmentations, you need to understand the architecture, the encoder architecture and the decoder architecture. So basically, I believe this will give you an idea of what we are talking about in terms of weights and all, right? Any doubts, participants?
Yes, sir. Actually, the optimizer that we have used here is the ADAM optimizer. So there are a few more like RMS prop and the stochastic gradient descent. So what is the exact difference between this stochastic gradient and RMS prop and this one ADAM? So which
So
one is
RMS
better
prop
performance wise?
yes, RMS prop is used in regressions, not in classification. So that is a mean
Okay.
square, root mean square error based propagation system. RMS is
Okay.
purely designed for working with regression when your dependent variable is numerical and continuous. For
Okay.
classifications, we use gradient descent. Stochastic gradient uses stochastic theory. So there is a Bayesian gradient descent also. So adaptive momentum descent uses derivative calculus. So the formula for ADAM will be
Actually, these things are very difficult to understand. Like
yeah.
this
So the
optimization
mathematics
algorithm.
behind this thing is a little bit complicated. So
So can you suggest me where I can find the easiest explanation of all this optimizer? Any
so
material?
medium only has it, but once you calculate only, then you will understand. So
Okay.
the best way is like for me also, once I did the neural network complete calculation only, I could understand the concept. So I will share this Excel sheet with you, which has all the formulas. Here we are using sigmoid activation with backward propagation and all. And here the gradient descent is the normal gradient descent we are using to adjust the weights. So using the normal value, this is the formula of the basic gradient descent.
Okay,
Yeah.
because I have read about this all this optimizer on the internet and like it is going
Yeah, you have
it's
to
not easily
calculate, ma'am. That
understandable.
yeah. So what happens is you have to calculate it. Once you calculate
Okay.
that basic calculation on an Excel sheet or by hand, then only you'll understand them. So this is the
Okay.
formula before it will take the first momentum and second momentum, and then it will update the parameters. So this is the formula which is used.
Okay.
B1 and B2 are the hyperparameters, the decay rates for the previous, and then derivative of the loss by derivative of weight. And it will take the second momentum variance and then it will update the parameter. So I'll try to share an Excel sheet. Just send me an email later where you can have these mathematical calculations done.
Okay, sir.
So once you calculate them manually, then only you'll be able to understand these concepts.
Yeah,
So the
actually.
mathematics have to be done. Otherwise, simply looking at them will not help you.
Okay, sir. Okay. Thank you.
So, any other doubts, participants? Okay. So let us
Sir,
initiate the
can
run.
you explain this summary that we are generating?
So for every layer, how many weights are generated? So if you look at the first layer, convolution data 64 units. See here, you can see here the first convolution 2D layer. It is initiating 640 weights. The second layer is initiating 36,928 weights. So then we are using max pooling 2D. It's a max pooling is a 2x2 kernel. So max pool and average pool are the methods to reduce the dimensions. Again,
These
in
parameters are
convolution,
nothing but the sorry.
pixel
This
values.
okay.
No, no. Which parameters you are talking about?
That summary, in that summary, one
That
column
summary
is
are weights, weights.
Okay. So
So I am talking about these weights which are initiated in the neural network. See here,
okay.
for every connector, a weight will be initiated. These are like your coefficients in regression. If you want me to give an analogy, these are like coefficients of regression, right? In regression, you have coefficients for every variable. So similarly, for every neuron and every connector that for every neuron, the weight for which it receives the input and the output, a weight will be generated or weight will be initiated. Initially randomly initiated, and these weights are adjusted by epochs and during backward propagation to make the predictions correct, or what you call to adjust the predictions. So this whole backward propagation concept is the logic behind the neural network's ability to self-learn and self-correct. So if I just, so these are the weights which are initiated for every layer of the neural network. And finally, after all the layers, we are getting in our model this many weights to be worked upon.
Okay,
Is
sir.
that clear? Yeah.
Yes, sir. Yes, sir.
So we will run the model.fit xtrain. Epoch is one full building of the network, and backward propagating to the network, that we call it as one epoch.
Sir.
Yeah.
Sir, in the program itself, it is in the previous step is still running. I changed that define paths for image and mask that I have done. Then whether we have to change that also.
Only thing you have to change is the paths. Only change you have to make is these two paths. Rest of all remains same. Don't change anything else except these two paths to your folder, data folder.
So that I've changed, but still it is running from that time.
Maybe you might not have activated the GPU.
Yes, activated, sir.
Okay. Okay, then just give me your NEDS number. Let me check. So I am sending the conversion. I have pasted the fit code also in the chat. Participants, you can take it from there. And please accept the connection request. Madam, I send a connection request on NEDS. Please accept it.
Sir, can you see my screen?
Yes, I can see screen.
This. I have written this, and then I was able to copy this code, but later I
One
was
second, let me do it. Please give me access.
okay. You see, sir.
I'm not access your screen. Can you scroll down? Madam, you have not given me the complete access, so I'm not able to access your system. Please accept the connection request again.
I have not got any, sir. Can you please send the request again? I have not got any request.
1 second.
Just a second.
It's again, you can see your screen.
You can see my screen. Okay, sir. This is my editor.
Scroll down.
Scroll down. Okay.
Go slightly up. Yeah. So what you have to do is move your cursor onto frames.
Yes, sir. I did that. I did that. This like this.
You pasted the paths, right? Close this
I
dictionary.
pasted. Actually, path was the same which you have mentioned. It was the same
Okay.
path.
So you ran the cell.
Yeah.
Shift plus enter.
Like here, I run. I go to run all.
Okay, you can do that also. No problem.
See here, but no output I get.
You will not get any output here.
Okay, no out. Okay.
No output.
So
there.
then next step is I have to paste the other code.
Oh yeah, you have to paste the model code.
Okay, the model code is
below that. I think that you are looking at the. Yeah, this is the model code. Till on top, not here. Little bit above.
Till above.
Yeah. This is the summary. This has to be pasted in this next cell.
Up till model summary, right now?
No. This is the second part. Or there is a full code on top. Just move your scroll. This is the model code. Till written model.
Like from import till
written model. Scroll down. You will have a model written. No,
Yes.
slightly above. No. Above. Please go above.
Sir, I'm doing it again, please. Return model, right?
Yeah.
Here.
Yes.
Command C. Here, code. Again, I have to code?
Yeah. And click on code cell. It will add a cell. Paste it there.
Now, sir. Now, run.
No. This is not indented. You have got it wrong. 1 second.
I don't know. Earlier also, I was getting like this only. Not indented.
Okay. Not intended. We are using Mac.
Yeah. I'm using Mac.
So Mac, it will create problem. 1 second. The indentation and all has to be there. So what I'll try to do is I'll put in a text file. 1 second. The rest of the participants, it's running.
Sir, it's a short code.
No, sir, I think the same indentation problem, I think.
So I'm pasting the
Mine
model.
is running. I am like model.fit is running. The epochs are running.
Epochs will run. Yeah.
Sir, now you can see my screen. I think now I have corrected.
No. Not 1 second, ma'am. I'm putting the code in the text file.
Okay.
So I'm uploading the. Oh, there is no upload file option. Sir, there is no upload file option. Huh?
Sir, you can send it to the coordinator so that they can paste it in the WhatsApp group.
So there is a.
Where it is? Sign message is there. Okay.
It is blocked, sir.
Okay. Uh, I think Nitin sir, you are there. Shall I send the text file to you?
Yes, sir. On my mail, sir.
No, WhatsApp.
Yeah, no problem, sir. You can send me on WhatsApp.
So I'm sending the text file on the WhatsApp. You can share it with the participants. Unit.
Okay, sir. No problem.
Because most of the participants are getting unintented code.
Yeah.
So you can, I send you on WhatsApp, sir. You can share it with all.
Okay, sir.
So once your model is running, you can see each epoch is taking, initial epoch is taking some time, 82 seconds, but the final epoch is run with 99 and 99 accuracy. So it's a very high accuracy we are getting on this data.
No, I shared on my WhatsApp group of this FDP group. All the participants can take. Yes, sir. You can continue.
Hello, sir. Can you paste the whole code over there?
You want the complete code in chat?
Yes, sir.
Sir, I pasted it up till there where you told me, but after that also I run it and no answer is coming. So next,
No, ma'am.
what
No. So indentation problem is there. So
No,
remove
I
everything.
pasted it well now. Sir, you can see my screen. If you can see my screen, I pasted it well. So I think now I have to, maybe I have to write the last line, the model line.
These lines you have to write. You have to, I'm pasting them in the chat. You can take it from there.
Okay, I'll take it and then run it once again.
Sir, you shared on WhatsApp, on my WhatsApp, so that I will share. Yeah.
Which one, sir? I already sent the text file to your WhatsApp, sir.
Text file or the entire code. If
entire code you want, okay.
yes.
Entire code. Return model. Sir, last line is not return model.
Last line is return model.
Then,
and then,
sir,
we have to compile the optimizer and the loss. Then you'll get the model summary.
प्रॉब्लम आ रही है ये वो नहीं हो रहा ना रहने तो वो आप भेजने टेक्स्ट
Oh, script is coming in a different.
Sir, you are sending the whole code?
Yeah.
Okay, sir.
Yeah, I have sent the WhatsApp in the complete code. My runtime got disconnected. Okay. Okay, participants, all of you got the code?
Yes, sir.
It's running for you guys? Okay, you want the notebook also? I can send you that in the notebook format. Nitin sir, I have sent you the IPNB Jupyter notebook format also. You can share it with all.
Okay, sir.
So if you are looking at this, biggest challenge here is getting the images data. The first biggest challenge is getting the images data. And I would suggest for images, when you're working on images and all, it is better to use Kaggle because Kaggle gives you 2 GPUs. The other place where you will find GPUs is Google Colab, but Google Colab provides you only with single GPU, even though you will get unlimited time. Google Colab, you will get a single GPU with unlimited time, whereas here we have 30 hours quota. You can see they have restricted the quota. It is a weekly quota, right? Per week, 30 hours. So it will say it for me the quota is 30 years and it will reset again on December 21st. So it's a weekly quota of 30 hours, but it gives you 2 GPUs. So Kaggle is preferred when you are doing large scale neural networks. It's always better to use Kaggle. The second place where you find is Google Collaboratory or Google Colab, unlimited hours, but it gives you only single GPU. And it's very easy to, you'll find the data available on now Kaggle has all the data available. You can just add input and search for the data, whichever you want. You'll get that particular data. You can just simply click on the add plus sign. It will add it to the notebook and run the cell. Even though the GB is 5 GB, 6 GB, whatever may be the size, it will add the data very fast on Kaggle. Another requirement for Kaggle is you need to have minimum of 20 Mbps speed internet. The higher the speed, the better the function with Kaggle. 20 Mbps is the minimum requirement of speed. Once you have that required internet speed and all, you can build and run the models at a very high, faster pace. So Kaggle is preferred, and it is always better to start with a pre-trained model. You will find the pre-trained models on GitHub. First, run the pre-trained model, see how much accuracy it is giving. Based on that, you need to alter the layers. If your model is underfitting, what typical neural network strategy we will do is you can add more layers, more convolution layers or more hidden layers to the model, add more neurons per layer, and then you try to see whether the underfitting is reducing or not. If you are suffering from overfitting, then it's better to remove some layers and neurons, and then you try to balance out the model. Now, the problem here is there are no fixed rules for deciding how many hidden layers should be there, how many neurons should be there per hidden layer. So there are no fixed formulas. It is all based on trial and error. It is all based on trial and error. It is based on experimentation. You have to get the right combination of layers. So it will take months to get the right combination, but there are a lot of pre-trained models. It is better to always start with a pre-trained model and work backwards or forwards based on your data set. So you'll find a lot of pre-trained models on GitHub, and the relevant research papers will also be available on GitHub. Use those papers, understand how they train the models, and accordingly you have to fine tune your models. Because the complexity in neural networks is hyperparameter tuning. Hyperparameter tuning means how many hidden layers we want, how many neurons per hidden layer, activation functions to use, how many pooling layers should be there, how much of the dropout should be used. All these things are hyperparameters which need to be tuned, and there is no fixed formulas. Only way is through random search or grid search. So grid search will take time. Grid search is where you can give different combination of neurons per layers and all. You have grid search algorithms also available on Python. Grid search with cross validation, without cross validation also. And then, but for grid search, it will take hours for running the models, and then it will identify the combination of the best possible combinations. That is how we fine tune the models.
Sir,
Excuse
my
me, sir.
question is,
Yes,
Sir,
please.
Sir,
how
here
to
it is giving that GPU session cap reached. Maximum interactive GPU session count of 1 reached. So stop one of your other GPU notebook sessions to continue editing.
Yeah, so on the left side bottom, you have to click cancel session. There will be on, if you see on my screen, left side, you can run only one notebook for one GPU. On the left side of the screen, you can see here, there is a triple box icon, view active events. Click on the
Okay.
tree side and then click on stop sessions.
Okay, okay, sir.
Stop all the sessions. You can run only one session per GPU at a single instance. Stop sessions. Then you choose which notebook you want to run and run all.
Okay, okay, sir. Thank you.
Sir, my question is, how to like finalize number of epochs is.
Now, number of epochs, the logic what neural network says is the more epochs, the more the neural network will have the opportunity to learn and do adjustment of the parameters. But again, we have the problem of what you call stagnation or constant or reducing. So there is no guarantee. What the theoretical says is increase the number of epochs, the network has more parameters to understand. It will fine tune and it will reach a, it will understand, it will perform well on the data. But the problem with this accuracy is also there is a point of stagnation. So if you are looking at, say, your epochs and accuracy as parameter, let us say if your model is starting from 0 and it will reach some point and then it will stagnate. See? And there is no point in giving more epochs here. There is no point in more epochs here. You will reduce the epochs to this point from which you are the values. That is why if you see the output, you will get for each epoch accuracy. Now, another problem also will happen. The another problem is after certain point, it will start jumping like this. Right? For this problem, we have to use something called early stopping.
Yeah, I know about this method.
Early stopping has to be defined. So what is the patience level you want to have? How many patients and what metric you want to finalize? Do you want to finalize validate loss or you want to do accuracy? Patient means how many times. So if it is going simultaneously 3 times down, you will say stop and stop the model, and that will be my final model. So you have to use early stopping. If the accuracies are jumping up and down like this way, if it is jumping, early stopping must be used.
Okay, so for example, sir, suppose defined epochs are 10, okay, and for the 7 and 8 epochs, I'm getting the same accuracy. Okay, now for the 9th epoch, I got the lesser accuracy as compared to the 8 or the 7. So at that time, I can set that early stop.
So you can certainly early stopping patients has to be set as 1.
Okay.
Or maximum we do two as the patient setting. That means if it is going down by two, second epoch it is changing, then it has to be changed. So you will find that how to set up an early stopping based on the output you have to decide. So if you look at our model, we didn't have that problem because we have increasing accuracy constantly. So we don't have this problem. So what you can do is then you can reduce the epoch to 8 only.
Okay.
Or you can increase your epochs to 20 and set a patient's level so that you can have early stopping at a higher accuracy.
Sir, can you please provide your email address first of all?
Yeah. No problem.
Thank you so much, sir. Thank you. And another thing, sir, can we save this notebook? How to save this notebook?
It is auto save. It is auto save in your Kaggle. On the left side, you will see code.
Okay. Thank you, sir. Thank you so
And then
much.
you will see your work will be there. It is permanent save.
Okay, sir. I just request you to give your email so that okay. Thank you so much, sir. Thank you so much.
So I'm pasting them in the chat also. You can take it from there. So somebody has an error. File not found error. Path error. You have to get the paths correct.
Sir, path already given as per your suggestion
Okay.
that right side that copy icon, then I paste over there, but still I got this message.
Ma'am, you have only pasted the frame cycle path. You have not pasted the mask. It says mask files not found. You might have forgot to paste the mask file. There are two files in our data, right? Frames and masks. So the error says that frames is there, mask is not there. So you have to give two paths in your data. So this is the way you can build a predefined model unit, and different versions of unit are there. R unit is there. Different versions are also available. This is the base version which I have ran in the model, the encoder, decoder, and the what you call basic model. So if you are looking at variants of unit, so this is one area where you see a lot of research is being done. Different unit architectures are available. So you see here different units are there. R2 unit, unit plus plus, SE unit, inception unit, attention unit, dense unit, residual unit. R unit is residual unit. So these are the different types of units which are there available. So here it is this they are using on retinal layer, eye retinal layer segmentations. So you can see here. So these all related things you will find these in TensorFlow, or you will find them on GitHub. These unit models. So these are the various types of unit architectures which are there. Today, what we have discussed, the basic unit. Unit plus plus is an advanced one. SC unit is there. And attention, inception, I don't think they work. But dense unit, I've seen a couple of research papers where they are proposing dense unit is a better for medical imaging, particularly 3D images, CT scans. Dense unit is what some research papers are proposing to be the effective architecture within unit.
Please provide some GitHub codes, GitHub links on which there is a research paper and GitHub codes. Both are there so that participant will get more information from basic to advanced. Yeah, if possible.
Sure, I will do that. Yeah. I'll send a thing to your WhatsApp group, WhatsApp, sir. You can send it to them.
Okay, sir.
They are in my Mac actually. So my Mac is not connecting to the what you call the Teams folder. So that's why I'm using my Windows laptop.
So one doubt is there, not exactly doubt, just I want to understand. Um, as you mentioned, data augmentation. So with the Kaggle, when we apply data augmentation, is there any specific limits for the augmented data? Like we can have only 7,000 images, augmented images, or the entire data set, it could be of 7,000 image, or any limit is there?
So we have this function in TensorFlow called image data generator.
Hmm. For that is used for data augmentation purpose, right?
Yeah.
So after applying this data augmentation, like
So
is
here you have a lot of these functions. So you want to do zoom range, shear range,
hmm,
vertical flip, horizontal flip, and all.
hmm,
Now it will not alter your image size. It will suppose you have 8,000 images.
hmm.
It will just work with those 8,000 images. It will not add new images.
Okay, but suppose
It
if I have
randomly
300 image, if I
okay.
have 300 MRI images, and when I apply 10 data augmentation technique like rotation and brightness or the zooming that image, so I must get like 300 into 10, right?
No. That is not how it works. It works on the same image. It will run the multiple functions.
Okay, so we don't
So
need to
for
have
that
a
you have to
separate
use different
storage.
software. You have to have different softwares. So that for that, if you want to have more images created out of your existing image,
Hmm.
that we call it as synthetic data generation.
Okay,
So
so
that is a
can we?
different field. So for synthetic data, Kaggle will work only with TensorFlow. So what happens in image data generator is it will randomly choose your existing images and it will do some images flip, some images brightness, some that only do. It will not add images. So what you're asking is you want to increase the sample size of your images,
Hmm.
right?
Right, right. Hmm.
So that for that you have to use synthetic image generation using a GAN, general adversarial network or something. These things have to be used.
I don't know, sir, but as per my understanding, we can see the augmented data image folder also with the Kaggle after applying the data augmentation.
You
So
can
is it a
see it,
part of
but
it?
it will not add images, na ma'am. You can see it.
Okay, but
But
is
it
there
will
any
not
limit
increase the
for?
images. See, I will show you. There is one model which we have worked upon.
Hmm.
So it will not increase the what you call the number of images. For increasing the number of images, you have to use GAN. Generator adversarial network is where we image. So you see here, the new images are created using these
Hmm.
adversarial networks. So there you will have, but if you look at in Kaggle image data generator, it will not add new images. It will work only on the existing images.
Okay, so what we see on the Kaggle after applying this data augmentation, that folder is like
So in
exactly.
this case, see here, I am using the ships data set here, train, test,
Hmm.
and valid,
Huh.
and I applied data augmentation also here. But the
Okay,
folder of data remains same. It will not change. So original data will say it will not affect your original data. The original data will remain the same.
okay,
Right. In the Python environment, that is what we are doing. We are not touching this original data. When you run the first cell, you are getting these images, right? They are coming into your environment. We are working
okay,
on these images. We are not working on this set of images. These have been imported in our Python environment in
okay.
Kaggle. And then we are running it. So I have applied an image here. You can see the data generator I have applied, but the number of images will not change. See here. I have 8,534 images. After made it target size, sorry, I did a scaling by 1 by 250, horizontal flip, zoom range 20, and shear range. Okay, and when I put it, my images are same 8534 images.
8534 images.
Same,
So
same,
is there
beautiful.
any limit to that particular number? Like here
That
we
you cannot
are
do
getting.
here. You cannot reduce the images using these two functions.
Okay.
You have to write a for loop and you have to randomly downsize the image sample.
Okay. Okay.
But the image data generator will existing images only it will play with. It randomly chooses some images, flips it, some images it zooms it, some images it improves the sheerness and all. Other than that, it will not do anything else.
Okay, but with the Kaggle environment, is there any limit for that? Like if we go beyond 10,000 images or what? Like
So Kaggle, instead of images, I would say the data size. If your data size is beyond 6 GB, then this free environment will not work. You have to take the paid environment. So what happened with one of the research scholar I worked with, she was working on diabetic retinopathy. The images were around 11 GB or 12 GB. So all the train test and valid images. So on base Kaggle, she could not run it. So she bought Kaggle is also costly compared to Google Colab. So what they did was she bought additional GPU on Colab.
Okay.
Google Colab, and then paid version of Google Colab. It costed her some 6,000 or 7,000 rupees, and then she ran the models.
Okay.
So in Google Colab as well as in Kaggle, you can work with up to 6 GB data, or I think less than 5 GB of data. Beyond that, you can't work on the free versions. You have to buy additional GPUs.
Okay.
And Kaggle is slightly costlier than Google Colab. So Google Colab, it's easy. Put all your data. You might have to buy Drive also. Drive if you Google Drive space also. Google Drive space plus Colab. I think total costed are 8,000 or something. It costed. So for 2 months or 3 months.
Okay, and for Kaggle, do you have idea about the costing?
Costing same thing for her Kaggle. It is costing around double the what Google was offering.
Oh. Okay.
So Kaggle is slightly costly compared to Google Colab. But that was around 222. But now I don't know what is the current pricing. I have not taken it. So data augmentation will not increase. You have to use synthetic image generators. There are some software applications available online. You can put your images there and then give how much data you want to augment. It will they will generate or increase the images. Decreasing of images, you write a for loop, use a random sampler and eliminate certain images by index.
Okay, sir. Okay. Thank you so much, sir.
Removing is very easy. Augmenting is the problem.
Yes. Thank you, sir.
Yeah. So in this chip model, we are running VGG, which is a version of convolution neural network. Day after tomorrow, I think we will run a couple of VGG net and all, which is an extended version of convolution network, deep learning based model. So this is also predefined model. So here we have 1 crore 90,000 43 lakh 1 crore 90 lakh 43,000 weights. So these neural networks, the complexity is the mathematical calculation involved. Once you have that mathematical calculation done, then only it will be there. So once you do the mathematical calculation, then it will be easy for you to understand. So any other doubts, participants?
Sir, what is the hardware requirement and software requirement for deep learning for more than 500 patients image?
Run it on Google Colab.
Okay.
Google Colab is easy to run. So if you are looking at, see, the problem is beyond 2 GB, because what happens is you have to download that 2 GB, upload that 2 GB into Google Drive, and then import it into Colab environment and doing it. So generally, if it is a what you call less than 2 GB data, I prefer doing on Google Colab, where you can build all your models and all. Okay, but if it is a very large data, then we have to.
And for hardware, sir,
for hardwares, you need to have GPU ones. So when you have your system with the GPU, then you have to use PyTorch to set up a CUDA environment, and then you do it. That requires a little bit of technical knowledge. So where suppose if you have system with a GPU, I think nowadays most of the labs have it. So there you have to set up a CUDA environment for each GPU, how much of the memory it has to be used and all. That CUDA setting up has to be done using PyTorch.
okay.
So what happens is when you're dealing with GPUs and all, like what we do in CPUs, the cores are pre-programmed by Intel. So we don't need to use them. But in case of GPUs in a desktop or a laptop, you have to define the cores and all. We call it as CUDA, CUDA environment definition. So that the GPU processors work well. If you don't allocate the memory spacing and all properly on the GPU CUDA environment, it will create problems.
Okay, sir. Is it possible to give any process or procedure for to setting these environments? If you have, then
I have old version. I'll just send me an email. I'll send you the updated versions because I worked on a CUDA desktop on a lab system in 22 only. I'll be working with a system in the December last week, so I'll send you the updated versions.
Okay, sir.
So here I am running a deep learning model on images only on Google Colab. So you can see it is also running fast. See, 20 seconds, 6 seconds and all. It is running faster only. The problem is uploading and downloading. So you can mount your Google Drive. On the left side, you see a folder icon. And the third one is your Google Drive. You can mount your Google Drive. See, this is your Google Drive. Once you click on it, connect your Google Drive, you will see the drive folders here. And the same procedures. You have to, like how you see in Kaggle, all your data folders will be there, and you click on these three dots, you'll get the paths to the data folders. So Colab is used to use. Again, the problem with Colab is also it needs high speed internet. So generally I prefer Colabs for your NLP, LSTMs and all. So LSTM for NLP and all those things, I prefer Google Colab only. For images related activities, I use Kaggle. Because image data will be large. Even NLP data is large. So here we are doing an LSTM network model, again neural network model with large scale data, tokenizers and all. So here also the network size is very large in crores of weights, and then it is taking around 160 seconds. See here, 160 seconds means it's taking around 2.5 minutes to run one epoch. So this is a fairly large NLP data. So the same thing will run on Kaggle in 100 seconds or less than that. So this is your NLP related models, LSTM model, long short-term memory network model. So we, for Google Colab NLP related work, Google Colab will be better. Even Kaggle is also better. But for images, we depend only on Kaggle.
Okay. Okay, sir. Thank you.
Can we use this LSTM for image data?
No. LSTMs are defined for sequential data.
Okay.
Sequential data means there has to be sequence, like time series data or IoT data, where there is a timestamp. Or NLP, text is a sequential data, right? So that only you can use. LSTMs are designed to work only with sequential data. Images are not sequential data.
Okay.
For images,
weather prediction and all we
CNNs
can.
have been developed. For images, only CNNs are there. You can't use CNN on NLP data.
Okay. Okay, sir.
So convolution, technically convolution 1D works, but it will be worst performing. Because text is a one-dimensional data, right? So convolution 1D is there, but it is no longer supported by TensorFlow. So convolution neural networks exclusively for images, LSTM models for sequential data, natural language processing, text data. For auto search, auto filling, all these activities,
Mhm.
Q&A, question and
Correct.
answering, all these things LSTM is used.
Okay.
So LSTM is also, you need to understand the basic context, the calculation and also. What I would suggest is for all, whatever neural network or whatever model you going to use, please understand the mathematics behind it. Then only you will be able to understand how it works.
Yes,
So
sir. Sir,
because if
please
you look at
provide
LSTM,
material.
so you see here LSTM comes with lot of gates, input gate, forget gate, and you need to know how it is calculated for each of these gates. So once you do a manual calculation, then only you will be understanding.
So
So
please
for
share
each
this
gate,
Excel sheet, the previous one also and this one also.
yeah. So until unless you do one single calculation of a neural net, here it is a recurrent neural network, LSTM and gated recurrent unit. So I will share this on WhatsApp itself, and this is the basic neural net calculation with backward propagation. So here I given 4 iterations, how the weights are adjusted, because we are trying to, the actual class is 0, predicted class is 1. So it is self-correcting. In the 4th iteration, the actual class and the predicted class are 0. So it will stop here. So this, once you do this basic calculation only, you will be able to understand. Okay. And even for the, now chat GPT is there, it is very easy to learn. Because it will give you the mathematical calculation also. So take for example, like Madam asked, Adam gradient descent calculation example. If you give, you'll get the, so you'll get the basic calculation here. You can run it on a notebook or you can do it in Excel also. So it will just give you all the formulas, stepwise calculation also. This is the beauty of ChatGPT. So which will help us to understand the calculations very easily. So stepwise mathematical calculation is also given here. So whatever you are understanding in neural networks, the activation functions, the optimizers and all, you have to do the mathematical calculation. So it is doing multiple iteration also. So first iteration, the 0.1. So how it is doing. So this calculation will help you to understand what that concept is all about. So this is the calculation behind this adaptive momentum estimation descent with numerical example. So it estimated, it assumed these parameters, it assumed a learning rate. Initial theta is 0, loss function is theta minus 3 square, and then it is reducing the gradient. And then it is updating the moments, parameter update, and in iteration 2, it is taking the input from the previous iteration and it is doing. So these type of calculations only will help you to understand the algorithms better. So once you work through these algorithms, preferably a pen and paper calculation, then all your doubts will be cleared.
Okay, so thank you.
Yeah. So you can use ChatGPT for all these mathematical calculations. The only thing is you give the prompt correctly. So calculation example, it will give you the stepwise calculation with example also. So any other doubts, participants?
Anyone having any doubt, please ask.
Thank you, Dr. Rajesh, for delivering such an informative and hands-on session on Kaggle. It was a pleasure to have you with us. With this, we conclude the successful second day of 1 week online FDP sponsored by Atal AICT on medical imaging in the third dimension, advanced techniques and clinical application. Wishing you all a restful night so that you can gear up for yet another exciting and informative session tomorrow. Good night and thank you. Thank you,
Thank you.
sir.
Thank you, ma'am. Thank you all.